Are we good to go? Good afternoon, everybody, and welcome. Thank you very much for sticking it out for those people who've been at the symposium for the last 2 days. It's rather impressive that there's people here on Friday afternoon. I'm sure you've got other options, but we really appreciate you being here so we can talk about our cluster of health policy, health services management. I'm aware there's people online, and this is also being recorded, so for people to watch afterwards. So I'm going to talk to the people in the room, but also the people online. I got the easy job of just introducing the actual health cluster. It really just brings together work we're already doing. So it harnesses the research strengths in 2 existing research groups. One which has been around for a while, the health services research and workforce innovation. The word workforce is a new term in there. And the second one is the value in health economics and policy, which is led by Francesco. As you can see, there's a picture of Francesco from 10 years ago and a picture of me in 10 years' time, I think, that they chose here. These 2 groups are very active research groups, and obviously Francesco leads our educational arm in the University of Newcastle on health economics management and policy. And I can tell you about some of the stuff we do. You can see sort of the list of what we're working on. But what I really want to emphasize is really what we're about. And that's we're impactful by engaging with stakeholders doing translatable research. There's no "and" in there for a purpose, because the research we do is engaged and translatable because it's engaged. So we have conversations, at the micro level, a lot of the workforce stuff that I do, at the meso level of the organization through different organization groups we work with, and even at the macro level, sort of government and system level type research that Francesco he leads, and it's going to be exemplified with some of the speakers we have today. The impact part, you see the word "act" is emphasized here. This is, again, a sort of a value proposition for us in the health policy and health services management space, that we want to do research that people can act on. So this is not an aspirational outcome, it's rather a design feature of the research that we do. The VEEP seminar series, which some of you may have seen, are absolutely exemplar in terms of creating conversations and collaborations. And I say that to sort of, with a little asterisk, in the sense that collaboration is assumed in a huge amount of our research, but it's actually really difficult. So we actually not only talk about collaboration, we collaborate together, we collaborate with regional, national, and international partners, and we also actually reflect on the actual process of collaboration and trying to create languages that people can collaborate more effectively with. So trans-specialist knowledge people talk about, sometimes we just simply talk about trans-specialist vocabulary so people can connect and work better together. So this research cluster that we have at Newcastle Business School is not new in the sense that we've been doing lots of research together and in different groups and with our partners at HRMI, partners in the Central Coast Research Institute, and obviously Francesco's sort of global network has not only been brought towards the school in terms of through the VEEP platform, but also to the university. So obviously you can't do research on health policy and health services management without connected to other parts of the university. So we are genuinely multidisciplinary, genuinely collaborative. And to the people online who are listening and may want to reach out, please do, because we're waiting to hear from you guys. And obviously, collaboration is really something that's not just a theme in our research, but a priority in the health system space generally. So we're positioned very well to sort of capitalize on the capacity we have. And obviously, our engagement agenda makes sure that when we're doing research, when we're developing educational programs, they are genuinely designed with the end user in mind. And I think that's a defining feature of this cluster, and I'm very, very proud to be part of it. So without further ado, I'm going to stop there and invite the Professor for PVC and Research for the university, Professor Brian Kelly, to give you a formal welcome to the university. Thank you very much.
Thank you, Brendan. It feels a bit like I've come in the middle of what's already been a very successful series of discussions and meetings that you've been having. But thank you very much. I'd firstly like to acknowledge that we're meeting on the lands of the Pambalong clan of the Awapaka people and pay our respects to their elders past, present and those emerging. As Brendan said, the value in health economics and policy team within the business school is an absolute asset for the university and the work that it does. And thanks to Francesco, Brendan, and the team, it reflects the university's genuine and significant priority in engagement, and one of those major engagement platforms for the university in its strategic plan is around better, healthier communities. And one way to achieve that, the most important way to achieve that, is by working together with our partners, Hunter Medical Research Institute, our local health district partners, other health service providers, the community, thought leaders, policy leaders, and healthcare practitioners particularly. And it goes without saying, and just to borrow a term that's been used in other settings, is the concept of more together, that we achieve more if we work together. And I think the structure of the sort of workshop that's happening today, the discussions that are occurring with a very accomplished panel that I think Francesco is going to introduce shortly, demonstrates that, bringing together the minds and expertise to think about how we respond to the very significant and challenging problems that we face in healthcare. And healthcare, or health workforce, is one we hear about on a daily basis in our media, as well as health policy and health economics. The challenges that we've been through over the last couple of years have really put that in the spotlight, but it's not going away. Despite talk about us living in a post-COVID era, we're not post just yet, and it's somewhat premature. So congratulations on the work that's being done, and particularly commend the outstanding work of the business school and the VEP team, and thank you for coming along here today, people here in the room and those online. And on behalf of the rest of the university and the Deputy Vice-Chancellor, Research and Innovation, Professor Z. Upton, who was unable to be here today, welcome and thank you.
Okay, well, thanks. I'll be very brief, and I would like to thank, of course, Brian and Brandon for the introduction. So we structured today in 3 sessions. The first one, it's the one that I'm going to immediately introduce, but don't go away. The second session, our HDRs are going to present their research and progress. And then we'll have a final session starting at around 3:10 until 4 that deals with issues in healthcare financing and digital health. And I would like also to invite you for the drinks afterwards. I don't know where they are yet, but we'll find out. Now, I would like to introduce the panel. I'm very honored to have you here. The speaker, let's say the one that will deliver the talk today, is someone that I know since I was even younger, looking at that. He remained the same, although he had an incredible career trajectory. He's an economist. Alex Robson is the commissioner and deputy chair at the Productivity Commission in Canberra. We met when he was at the ANU working on a number of issues, and we motivated each other in thinking about the structural problems of the Australian healthcare system back then. And that was the time of Karen Rudd and the National Health and Hospital Reform Commission. We did quite a bit of work on the model that was devised and designed to really reform the system, called, unfortunately, I would say, Medicare Select at that time. Well, Alex, since then, has had a number of very high-level appointments in government, and recently has been our ambassador of Australia to the OECD in Paris, and recently returned to join EY, and finally now is at the Productivity Commission. So I'm very thankful for him to have been coming to be here, to have made his way to share his thoughts around productivity and workforce challenges and opportunities in healthcare. Now, the panel that will follow the presentation of Alex includes Rod McKinsey, who is the CEO of Honeysuckle Health. Thank you, Rod, for being here. He has a very long and established career in the healthcare sector, in the private sector in particular. So again, thank you to be here. We have Francis, Professor Kay Lampkin, joining us, distinguished professor at the university, very successful. I'm really going to fail. I tried to kind of list her achievements. She's also the director of HMRI and thriving in that role. Thank you, Francis, for being here with us. Thanks also to Michael DiRienzo, who's been a great supporter of the business school, and he's a professor of practice as well as the CEO of Anto New England Health. We're very thankful to have you here and to keep engaging with us, and of course, also in the discussions that we will have today. I'm also extremely thankful to have Dr. Fong here all the way from Perth. I met Neil a long time ago as well, when I was in fact myself in Perth. He has been in the sector in management roles, government roles for over 3 decades. He has a great deal of experience, not only of course in workforce, but I'm extremely delighted and thankful for him being here. We have a very long-standing partnership, and our programs are accredited with the Australian College of Health Service Management, of which Neil is the president. Now, Alex, I would like to welcome to present to our audience. How do you do? Don't save. I hope these are your slides. Alex.
Thanks, Francesco, and thanks for inviting me today. I've forgotten about how you looked back then when we first met. I guess it's more than a decade ago. So look, it's great to be here. The last few years have been very challenging time for economies in general, but in particular the health sector. So I was over in France right in the middle of COVID, and I think it was a scary time, most of all because I think the countries that were first affected was Italy and Spain, and looking at the French health system coming from Australia in that context was, as a foreigner, a little bit frightening, I've got to say, but it all worked out in the end. But it was a very challenging time and an interesting one for health systems around the world to try to cope with. So what I'm going to talk today about is a little bit more of a longer run look at healthcare industry productivity from the perspective of the issues that we're looking at in our 5-year productivity inquiry that's going on at the moment. So I'll talk a little bit about the Australia's productivity challenge in general, what we've been asked to do in this inquiry that's reporting in February, and what we found so far and some of the themes that are emerging, in particular as they relate to the healthcare sector. And then at the end, as a bit of a motivation and precursor to the panel discussion, I'll focus in a little bit on healthcare and talk about some of the specific challenges and opportunities that arise there. So Australia's productivity challenge, why do we care? So productivity basically defined outputs per hour worked. This is over a 110, 120-year period, GDP per capita versus labour productivity. And there's a famous quote from Paul Krugman that you may know, I won't repeat it, but basically, GDP per capita, or our long-run living standards, are almost entirely driven by labour productivity. Okay, so improvements in technology, innovation, skills, knowledge, better ways of doing things, better ways of organising the economy, openness, all of these things that I'll talk about throughout the talk. If we want to have a discussion about long-run living standards, we've got to have a discussion about productivity growth. And that's manifested in real wages growth. So if we think about labour productivity, how many outputs per hour worked, it's strongly correlated with real wage growth. Now, there's the debate that goes on about measurement and so on, and people discuss this, but it's pretty clear from the evidence that we see that labour productivity and real wages go hand in hand. There's some deviations that happen if there's a mining boom or certain other things, but in the long run, the pay packets that people take home on average are driven by this labour productivity growth. So that's why we care about it, because in the long run, that's how living standards are determined. And when we talk about living standards, we're not just talking about money in people's pockets, although that's important. We think about the quality of goods that are produced, the variety of things that are produced, the variety of services, the characteristics of those things. All of those things are a dividend of stronger productivity growth. One dividend in particular, and this gained a bit of media attention when we were talking about it right at the beginning of our 5-year productivity inquiry, was that this idea that if you can work more effectively, so working smarter rather than harder, that gives you more time for leisure. So you can take an extra day off, extra hour off, and that's been the experience on average in Australia over recent periods. There's been a reduction in hours worked on average, okay, even though consumption and output have gone up. So that's part of the productivity dividend as well. And you may see these discussions around a 4-day week. That would only be possible, only feasible if there's some productivity gain to be able to say, well, you can do your job in 4 days rather than 5 days, or share it with somebody else, or if that's feasible. I'll come back to that maybe in a little bit. There's a debate in the literature around and among the public around whether long-run productivity growth, is sort of negatively correlated with other things that people care about. So this is the well-being debate, and that's a very interesting and important debate. If you do look at a lot of these other indicators, though, it turns out that productivity growth is correlated with those things we care about. It's not perfectly correlated, but often they do go hand in hand. So inequality, I'll come back to in the next slide. Life expectancy is strongly positively correlated with productivity growth. So as countries get richer, they can spend more on quality health care, preventative health, all of these things that if that's what consumers want, then they have higher incomes to be able to afford it. And even these measures of life satisfaction, which is sort of survey data, how do people feel? It's strongly correlated, at least in the cross-section of countries, with productivity growth as well. So in the Australian experience has been, we've had this strong productivity growth. Absolute poverty has declined. Relative poverty, which is a measure of inequality, it bounces up and down, but there's no strong positive correlation there between productivity growth and inequality. We just can't see that in the long run data. So it's an important lesson there, is that there's not necessarily, we don't have to pay for reducing inequality by giving up productivity growth. There's certainly a policy debate around different policies and whether they are better for inequality or not. But on average, we don't see that this long run productivity growth necessarily is bad for inequality, and certainly it's a good thing in terms of absolute poverty measures. So that's been a bit of an introduction. What's been going on in Australia in the last decade in terms of labour productivity growth is that we're at a 60-year low. So productivity growth is strongly correlated with real wages growth. It has all these other benefits, but it's not performing well in the last decade. And in fact, it's the worst in 60 years. So that's why, we've been tasked with, one of the reasons why we've been tasked at looking at this in the 5-year review is that of Australia's relatively poor productivity performance over the last 10 years. So it's 1.1 is the red bar there, and the 30-year average is 1.6, and the 60-year average is 1.7. That's not unique to Australia. There's been a productivity slowdown right across the OECD. The light blue bars there are the 25 years from 1980 to 2005, and the dark blue ones are the more recent period. And just looking at that data, eyeballing it, I think it's true in every country that there's been a productivity slowdown, except it looks like Israel and maybe Switzerland as well. But in every other OECD country, and certainly in the average, it's more than halved that growth over the last 15 years. So the question is, well, why is this happening? It's not unique to Australia, but that doesn't mean that we can't do anything about it, and we shouldn't seek to do something about it and address some of the issues in relation to productivity performance. One of the things you notice straight away in the data, and this was surprising to many, we were talking about it this morning, was in relation to services. So Australia is now 80% services in its GDP and 90% services in terms of employment. It's been similar numbers for a very long time, but it was a bit of a revelation to some people when we put out the first interim report in terms of this inquiry. But it's one of the issues when we look at services is that the characteristics of productivity growth in the services sectors are very different from the kind of productivity growth you might observe in, say, manufacturing or agriculture. Okay, so if you think about a factory, you put in a new piece of equipment, you produce more stuff per hour, you can shed labour, and that's what a typical productivity gain might look like in manufacturing. Agriculture, you might have better crop yields by improving planting practices or better disease management or better harvesting. But in services, it's often not like that. Okay, so one person in the media asked me in an interview, could you do your job in 4 days a week? And it's a really good question. And I should have said to her, well, could you do your job 4 days a week? Because she was a radio drive time announcer, and you have to do 5 days a week radio. So you couldn't, basically. So there's this thing about services where the productivity gains, if we're hoping to get them in services, and healthcare is sometimes an example, where the characteristics of what a productivity gain might look like in that sort of sector can be quite different from what we normally think about. So it might be improved quality of service, different varieties of services, more focused on the individual consumer and their needs. These are the kinds of things where you'd expect, if you're going to get a productivity gain, that might be what it would look like, or a better organisation of how the service is delivered, or better processes. It's often not just, we'll install a new piece of equipment and we'll get rid of people and we'll get a productivity gain in terms of the way it's measured. So why is that relevant for this data that I've got up here? Well, the prices in many services have outstripped the prices of goods in terms of growth. So in all goods and services, if we just look at the left-hand panel there, there's been price growth on average that's exceeded goods price growth. In medical products, it's it's a stark picture there. So part of that is obviously going to be quality differences, quality improvements, and so on, and clothing as well. All right, but there's this clearly it comes out of the data is you've got these cost pressures in services that are not happening like it is in the goods part of the economy. And we're 80% services now. So that's why this kind of data is very concerning. Our labour productivity performance is strong for goods, but much weaker, although improving for services. So there's some aggregate data there on the left-hand side, and in terms of the ranking of different countries for services, which is the blue line there in market services, we've improved our ranking a little bit, non-market services as well. The distance from the frontier for those two things it's a long way from the frontier relative to where we are for goods. And part of that in there for healthcare is going to be non-market services. Healthcare is a key part of that. And finally, just in terms of the service sector, that's been growing as a share of the economy, and we'll come back to that. And it's largely attributable to the growth of these non-market and business services. So why is that happening? So you may have heard of the Baumol cost disease issue. So William Baumol wrote a paper, I think it's in 1967, we wrote a couple of papers, but there's a 1967 paper where he talks about this phenomenon of services industries, and he uses the example of I think it's a string quartet. And the idea was that when we go out and measure aggregate productivity, or on average, there are going to be some sectors where productivity growth is above average and some are below. That's just mathematics. It's got to be some are above and some are below. And that's fine if the services, different sectors are jumping around. Some are above average some years and some aren't in other years. What Baumol was talking about, though, is that there are certain sectors that are systematically below the average in terms of productivity growth. And I said, well, why would that be the case? If you look at those services, and he used the example of a string quartet, it's very hard to secure a traditional form of productivity gain in something like a string quartet. It's 4 people, they turn up, everybody listens to them, they play their music for whatever it is, an hour, and then we all go home. Right? So that was the case when Mozart was around, and it's the same today. You need 4 people in a quartet. You give play the music, and then away you go. So labour shedding in a string quartet, well, you could go to 3, but it wouldn't be the same service that you're providing. And so Baumol looked at this phenomenon and said, well, if there's going to be some sectors in the economy that are growing faster in terms of their productivity growth and others that are stagnant, and if wages have got to be paid and equalised in terms of growth across these sectors, then costs are going to go up for people who play string quartet. And what we're going to observe is a growing share of the economy that's going into payments for things like a string quartet. And then we'll have this unbalanced growth over time. Now, when that paper came out, it was very controversial. If you go back and read I think it's in the American Economic Review, lots of back and forth. Joan Robinson chimed in, lots of people, big argument. But then Baumol wrote a book, I think it's in 2012, where he said, well, it's not really such a big problem because what's happening in that situation is we're getting richer from this stronger productivity growth in these other sectors. Our incomes are going up. The fact that costs for string quartets are going up, that's okay, we can afford it. We'll just go and pay more to watch a string quartet and it's all good, okay? So it's a little bit of a summary, but it's one of the things, if you go and read his book, he starts out saying almost exactly that. And the thing he's trying to say there is that, well, a productivity, growth in a certain sector, it can't make us worse off. It might shift our consumption and our spending between those two sectors, but it can't make us worse off, even though it might look like a problem that we're spending more and more on certain things. But he does then point out that, well, if that's the end of the story, then that's fine, but it may not be the end of the story. So if we think about the other this lagging sector as, let's say, healthcare, then it may not be relative costs are going up in healthcare because of just this lagging productivity growth. It could be because there's waste in the healthcare system. It could be that actually if costs are going up, then if the incidence of those costs are falling a lot on people with lower incomes, that's a problem. If it's the case that people in the healthcare sector are funded by governments or hospitals run by governments, then that implies then that the relative size of government is going up, and so we have to tax people more, so that has other productivity implications. It might be a problem if the things that we're seeing in productivity improvements in actually create negative externalities. So it could be, and he uses this example, what if it was that we're seeing lots of productivity growth in the weapons production sector? That's not necessarily a good thing, okay? Or in something like the coal sector where we might get more emissions. So there's all sorts of caveats to that, but his basic point in that book was, well, the cost disease itself is not the problem. The problem is potentially all these other things. And often we may not be able to tell whether it's just his original cost disease issue, which is just different rates of productivity growth, or is it because productivity growth in the lagging sector is artificially being held back because of poor practices, or deliberately held back because of institutional barriers, inappropriate regulation, poor adoption of technology, all of these other things. The fact that it's below average, well, somebody's got to be below average. So it may not be any of those things, but it could be. So that's the difficulty. So that's a bit of a context for this 5-year productivity inquiry, and I'll come back to healthcare. What has the government asked us to do? So the Productivity Commission, our mission is to provide independent research and advice to government on economic, environmental and social issues, on issues that matter to the Australian public. So that's where a research and advisory group. And the government every 5 years asks us to look at Australia's productivity performance right across the board. Okay, so in every sector potentially. And then to provide an actionable roadmap for implementing reforms in whatever areas that we look at. So that's a big task. We had to be selective in what we looked at this time round. If you go back to 2017, the title of the report back then was Shifting the Dial. Some of you may be familiar with it, and there's large chunks on the health sector in that report. And it turns out that not a lot of the recommendations have been adopted. So to the extent that they still apply, we just repeat them in this report. So what we've done in this time around is look at 4 different sort of categories of things. One is data and digital. Okay, so looking at the dividend to productivity from data and digital innovation in Australia's economy. Another one is on the diffusion of ideas across the economy. So it turns out that 98% of Australian businesses aren't producing this new-to-world innovation that we always think about in our heads as innovation. What they're doing is adopting or adapting an idea that's already out there. So if that's 98% of businesses, it's over 1 million businesses, there are potentially big productivity gains from those businesses reaching best practice or the frontier. And that includes healthcare sector as well. So that's the second part of what we're looking at. The third is on education and skills. So we look at schools, vocational education and training, and universities, and some ideas for reform there. And then the final one is the business environment, where we look at everything from climate to competition policy and dynamism, openness and trade and foreign investment, industrial relations policy, the gig economy, and migration. So there's obviously things that we haven't included in those interim reports that were just released over the last 6 weeks, but even though you might have left a bit out, I think there's still, I don't know how many hundreds of pages, 800 pages of material there that we're moving towards a final report in February. So some of the major themes that we've looked at and found as we've gone along, well, one of them, and it's relevant for healthcare, is this idea that there's businesses and organisations that are at the frontier, and then there are a whole bunch that aren't. So there are big gains, we think, from in whatever sector you're talking about, being able to find out what the frontier looks like and implementing best practice. And so making best practice into common practice. That's particularly true in schools, in hospitals, it's often the case, and in just a lot of businesses. It turns out that the data in Australia shows that managers, on average, don't even compare themselves with the frontier. They don't know what the frontier looks like. And so that's a big concern, because then they're not looking at ways to improve. They just don't have the information often. They don't know where to look for it. And so that's one of the big themes that's emerging. Another big theme is building adaptable workforces and workplaces, and I'll talk about this in a little bit as it relates to health. So that's on everything from industrial relations flexibility to improving our migration system, making sure that we, with respect to the gig economy, that we don't try to shoehorn that business model into a traditional employer-employee relationship, and all the institutional arrangements that come with that, because it does provide, particularly in healthcare and aged care in particular, some real benefits to consumers. And we've got another report on that we released recently. So that's another big theme. And then the final theme is just securing the conditions for efficient markets and wise investments. So this applies across the board. So everything from climate to public investment, energy. It's obviously something that you'd want if you want a productive economy. So those are some of the themes that have emerged so far. So the goal from here in terms of that final report is to actually come up with concrete recommendations in terms of policy for government. What can they actually do to help achieve these things in different sectors? So some of it, as I said before, a lot of the recommendations from shifting the dial are still relevant. There's other recommendations that the Commission has made in the healthcare sector, and I'll talk about those as well. So what is the productivity challenge in healthcare, and where are the opportunities? Well, in terms of workforce, on average in Australia, there's this nice data on the kinds of tasks that people are doing rather than the jobs that they're doing. So non-routine cognitive skills, the demand for those is on the rise, but routine manual and routine cognitive skills are on the decline, and non-routine manual is very low, still chugging along there. But there is this big demand out there for non-routine cognitive skills in the economy. So that's how the Australian labour market is evolving, not in terms of jobs, but in terms of these characteristics of these skills that you've got to have. So that has implications for migration, education, occupational licensing, the transferability of employees between different jobs in the same, in the same workplace or across workplaces. These kinds of skills are the ones that look like they're growing most rapidly. This might be familiar to you. So the share of healthcare and social assistance in terms of overall employment in the Australian economy over the last, 40 years, has almost doubled. Okay, so there's this big shift in the labour force out of other forms of employment, whether it's manufacturing or whatever it might be, and into healthcare and social assistance. Okay, so that's a big, that's a big aggregation, but that gives you that overall picture. It's gone from 8% to roughly 14%, and it looks like it's heading up. So this is, part of the, if you had sort of bone mole cost disease this is exactly what Beaumont was sort of talking about, okay? That you get productivity improvements in some other sectors, and then you shed labour in those sectors, and they go into these sectors where almost by definition, the labour can often be the good or service that you're providing, right? So that is the service, it's the person. And shedding labour in that kind of environment is very difficult, okay? And so we have to think of other ways of potentially improving productivity. So I'll just talk quickly about one example of what's been going on in terms of productivity in Australia's healthcare system, and that's in hospitals. So there's this it's experimental data that the Australian Bureau of Statistics has put out on productivity in hospitals. They look at public and private hospitals. Now, in terms of measurement, hospital outputs, they look at things like admissions, emergency services, not admissions, separations they look at, and various other output measures of output. So you can debate whether that's really quote unquote output or not, but I think it's probably reasonable. So that's in terms of volumes. Hospital outputs have been rising quite rapidly. So if we look 2004, 2005, the index there is 100. It's basically gone up by more than 60% over the last, say, 15 years. So that's a big increase in output. Labour is the largest cost share in hospitals, so around 60% on average. It's slightly lower in private hospitals, but it's the biggest share. And labour inputs have been rising. That's over the last 10 years. Labour inputs have risen by 40% in Australia's hospitals. So if we're looking for, one of the reasons why we're talking about healthcare workforce today, this is one of them. And it's just outputs are increasing. It's a labour-intensive sector. It's demanding more people. And that's the basic arithmetic of it. Now, when we come, though, to our measures of productivity, over that same period, just was in the previous slide, they're basically, I think it's a 5% increase, but it's basically flat. So labour productivity is that light blue line right there at the top. It goes up and then it goes down and then it goes up. Multi-factor productivity, which is a measure of your innovation, technology, whatever's not embodied in labour and capital. It's this sort of residual that economists often think about. So better ways of organising how business is run, better processes, knowledge and skills. That's what multi-factor productivity really is. And that's basically stagnant over the last 10 years in Australia's hospitals, according to these measures. If you look at the same kind of data for Australia's schools, it's actually a lot worse than this. It actually it goes down, falls off a cliff almost. Now there's caveats to the data, but it doesn't paint a very good picture in terms of schools and hospitals. It doesn't look that good either. But as we said before, securing productivity gains in these kinds of sectors, we'd expect it to be more difficult than in, say, manufacturing and other areas. It's part of the challenge. So what are the sources of labour productivity growth been? If we break it down, so in some years, the ABS says there's improvements in technology. In some years, technology goes backwards. It's hard to believe that that's really what's going on. But nevertheless, that's what the data says. And there'll be jumps in these things from year to year, which might be measurement issues and so on. But the basic point is that over that 10-year period, multi-factor productivity has been flat. So what are the opportunities then, given all that, in the healthcare sector? So the Commission has looked at the sector in a lot of detail. So I think, Neil, you were telling me about a workforce report in 2005. I didn't go back that far when I was looking at preparing for this talk. There's an efficiency in health report in 2015. As I said, shifting the dial in 2017. There's a mental health report that we put out in 2020. So there's lots of recommendations in there regarding healthcare. One of the examples in terms of innovation that we looked at in the innovation interim report was just in activity-based funding. And so I think that was originally adopted, I think around 17 years ago. And although it's got some drawbacks, it took 17 years for it to be adopted in Australia more broadly. So that's part of the challenge in healthcare is, I think we were talking about it before, we can make all these recommendations, but they just take a long time to be implemented for various reasons. So what are some of the things that have emerged as part of all this research? Well, one is this idea of patient-centred healthcare, and it's really getting at that idea that I talked about before, which is a productivity improvement in healthcare may not, it's not going to look like installing a piece of equipment. It might be, well, let's find out what the consumer really wants and better target the service to that person, whatever that might look like. So that's, in some circumstances that's going to work. In others, it may not. In some cases, it may involve higher costs. In some, it might, lower costs overall. But that's this idea, is that trying to secure a productivity improvement by improving the quality of service or the characteristics of service. That's how I think about patient-centred healthcare in that broader context. Another idea, general idea, is the diffusion of innovation that I've talked about. So, hospitals and other healthcare providers, how far away are they from best practice? So it turns out that there's many opportunities to improve not only a technology improvement, but more to the point, better processes, better ways of doing things, better ways of organising healthcare systems. Those are the kinds of things that they're still innovation, but they're not the kind of innovation where you've suddenly got a new invention and whiz bang and it improves the health outcomes in that respect. Technology, well, there's a big role for technology. It's not a silver bullet, but we saw that during COVID. You think about things like telehealth and e-health more generally. So that offers potentially productivity improvements if it can be done well. And then there's the more traditional forms of technological improvements that we think about in the healthcare sector. Occupational licensing is an issue that we've looked at in the interim reports, and the issue here is, whether a licensing arrangement creates artificial barriers to entry in some professions, and whether they can be, relaxed or changed, in particular in relation to movements across different jurisdictions within Australia, but then also from overseas. If we've got a workforce problem, it's an obvious thing to look at in terms of migration. I mean, one of the examples that we found in the interim report was where you could, you could get come in as a nurse from overseas, and you could get all the points in terms of the skills list that you might need, but then you couldn't qualify as an Australian nurse because of the differences in qualifications, and there might be a lag between when you could actually qualify for the skills list and actually work as a nurse. Okay, so there's these barriers here in certain professions where it doesn't make a lot of sense from an economic point of view. Now, there's obvious safety and quality trade-offs that need to be carefully thought about in the healthcare system in relation to occupational licensing. But if we're talking about workforce shortages and workforce issues, it's got to be something that's mentioned. Another one is scope of practice. So this is this issue where you can have someone who's got a range of skills and they're very highly skilled and highly trained, and you don't necessarily need that person to perform a certain healthcare tasks like taking a temperature or providing a vaccine. So we saw, pharmacists during COVID could provide vaccinations. So there might be opportunities there in terms of mismatch of skills or overskilling, where you could get productivity gains out of modifying those things a bit. Again, this is all subject to careful analysis and thinking about the benefits and costs of what you're doing very carefully. And then the old one that we always come back to in healthcare, which is funding models. So these can often be a barrier to innovation and flexibility. You get paid for operating in a certain way. If you don't do it a certain way, you don't get the money. That creates potentially big barriers for finding new ways of doing things and finding productivity improvements. So those are the few things that I've mentioned there. As I said, we've covered all of those in previous reports at the Commission. What we wanted to do in this report that we're releasing in February next year is to come up with, well, we've said all this before, is there anything new we can say in relation to health? And that's the challenge, and education and these other things. We wouldn't want to put out a report that just said, oh, here's 50 pages on explaining why we said this 5 or 10 years ago. We want to be able to say something new. So we're keen to hear feedback in venues like this and in hearings and other places and submissions. But I'm very keen to hear from our panel today and have that discussion about workforce challenges in health, given that we've got this big increase in employment in the healthcare sector. It doesn't look like it's going away. But the problem in Australia is we've got, well, it's a good problem. We've got 3.5% unemployment, and every sector is crying out for workers. So if you want to be able to say, oh, let's have an extra spot for a nurse or a doctor, these days you've got to say, okay, well, does that mean you want fewer teachers? So it is, it's a great problem to be able to have, but it nevertheless is a challenge for Australia going forward. It might be a short-term challenge, or it could be something that's very long-term. But the challenge in healthcare, as I said before, is this: it's the labour intensity and some of the practices that you might get locked into actually reduce your flexibility. However, you might be able to change it, and that's the challenge for productivity in these sectors. So thanks very much for having me. Yep. I think you should just be able to talk into it.
Okay, this one. Right, thank you, Alex. Much appreciated. Now I'll go around. I'll walk you and need to move on. It's not easy territory to walk around and get your thoughts. And we'd like to start and leave this slide, which I really liked when I saw it, and it contributed also to match our panelists. In fact, we have an ideal panel to tackle each one of those points. So we'd like to start with not such a new thing, but certainly new in terms of its impact, which is e-health and telehealth, which has boomed really during COVID. I'd like to invite Francis to comment on that particular topic. And in particular, when it comes to workforce, it offers a great opportunity, at least theoretically, because you can access physicians or practitioners everywhere in the world. But again, there may be barriers to it, and so on. Francis, please.
Thank you very much. Should I stand up here so people online? Miss a chance to get on camera. Thank you. It's a really good question. As you were talking, I was thinking about my context of mental health and e-health, and how during COVID particularly, although we had an influx of practitioners and clinicians willing to and us engaging in telehealth and integrating technology into their practice, really what that amounted to was a lift and shift. So doing what they were doing face-to-face in an online virtual environment. And in the context of, patient-centered healthcare, scope of practice, and, an increasing demand or reliance on those non-routine cognitive tasks and workforce, I think that really means that if we are to realise all of the potential opportunities of e-health, we actually need to think about how we deliver care in a very different way. And so we don't just need to lift and shift, but there are certainly ways, and our research is doing that as well, to delegate some of the routine non-cognitive tasks or aspects of mental health care and counselling and those sorts of things to automated programs and apps and things like that that can do that and free the clinician time up to be spending on those acute or crisis things you can't automate that are just routine. And I wonder if that's a way of creating some efficiencies within the current workloads in some of our services by thinking about or by us checking our assumptions that the way we're delivering care is actually the way we need to be delivering care. So I think there are huge opportunities and big gains that we can make rather quickly.
Thank you, Francia. You can stay wherever you want. I think stay there. It was a soft invitation. You're next. I would like to ask more directly in relation to the occupational licensing and the challenges in the healthcare industry at the moment. Obviously, there isn't much availability of professionals globally. Everybody's facing the same problem. So, if we were going down that path, what would you? What would be your thoughts about that?
Thank you, Francisco. Look, we have to be very careful about this issue about relaxing license because we also enjoy one of the highest quality outcomes in terms of the health of our community in the world. And that's not to suggest that people coming from other countries don't have those same skills or qualifications, but we need to be. It's a very careful one. It's a very one we need to be very careful about. I think it needs to be a focus back on our own training sectors in the universities and the TAFE areas as well. We haven't looked at the model of health education or medical education probably for a long time. So how do we train young doctors, for example? And after 6 years or a 5-year program or a 7-year program, if you're doing it 3+4, they've still got to do a whole year of internship to learn how to be a proper doctor. There's a whole efficiency area in that internship year in our medical training programs that I think could be looked at. And in Canada, you might not be aware, but they don't have an internship year. So they're job fit and they're ready and they hit the ground running. So I think there's probably more we can do in that space of our own people to kind of make them available more quickly. In terms of relaxation of licensing from other countries, look, I think there is some aspect where we could improve that. But there's this whole ethical issue about dragging people from other nations as well into Australia. And you might not think that it's... and so we have to become self-sufficient. So I was involved in the development of Australia's newest medical school at the Curtin University 5 years ago with huge opposition from the medical unions about, no, we don't need any more doctors in Australia. Well, go figure. We got it up in the end, but the whole argument of that was that why I got it up in the end with the politicians was, well, we were dragging people from the UK and Ireland and other English-speaking countries, but they were dragging from the African continent, which became a real problem in terms of the healthcare in those nations. It wasn't ethically right, so it made sense to train more, and we need to train more, and we probably need to train them in a different way. And the other thing is, I don't think we've had a new health profession invented for our health needs. And I think, with the digital kind of explosion and requirement in our healthcare systems, that's what we really need. And clearly, everybody has to be very much digitally enhanced in terms of their training. Anyway, there's just a few thoughts.
I love that. That's great. Thank you. Michael, I come to you. If you wish to basically connect with the response and the presentation of Alex and his friends and Neil's point, what comes to mind is whether there is any capital in the existing stressed workforce after COVID globally feels in that way, but whether there is any room or ideas from a management perspective in things that are being debated intensely around task shifting, whether they can in fact be a form of gains in efficiency.
Thank you, Francesco. Again, Thank you for the presentation. I think a lot of what's been mentioned is basically pretty spot on about where the health industry is at the moment. If I can just touch on a couple of things, the telehealth, or we call it virtual care these days, we're very good at changing some of the jargon around health. I think one of the things that we need to do is ensure that we don't go backwards here. So one of the things that COVID did allow us to do was to shift the culture around the use of technology like the digital platform, but more importantly, the old-fashioned video conferencing, and basically saying that telehealth is not just a phone call between a patient and the clinician. We can actually use the technology, and that was a major uplift. But I can tell you, as a chief executive of a very large local health district and part of the New South Wales health system, there is already a trend to move back to the old way of doing something. And I think that's fundamentally what we need to do to improve productivity, is to actually not go back, but to keep going forward. I can give you examples of where we are actually, and if we sort of link some of this in, if we are patient-centred in our healthcare, then virtual care is patient-centred. When our local health district embarked on virtual care probably 15 years ago, it was around being patient-centred, because if you actually look at what you actually do for the patient, is you actually save them from unnecessary travel, which is also a major tension point, and it's actually not well for their well-being in the first instance. Plus, the other aspect of it is, apart from that aspect, it's also much more productive for the clinician. So if we talk about productivity, you work out, I have a district the size of England. So you work out how much non-productive time is in actually travelling to do an outreach or to do some work outside of a base hospital for a particular clinician. So again, the message there is, but we also have to move away from calling virtual care basically the use of a telephone or the use of Zoom or whatever technology we're using. The the new approach to virtual care is actually making it a complete service with the diagnostics attached, the medical record attached, and a lot of the work that we're doing at the moment is actually in that direction. We now have a situation where you don't have to have the doctor physically in the hospital. And the reason you don't have to have the doctor physically in the hospital, because we've actually created all the complementary systems and given the doctor and the community and the patient the confidence that they're going to get exactly the same service. So I think the future of the productivity here is what we've got to do is ensure that we can reinforce and give the community confidence that they are getting exactly or a better service than sometimes relying on having the productivity of the doctor or the nurse or the clinician inside that particular hospital setting. In terms of then occupational licensing, I've got to say I agree with you. But my experience as a chief executive of a large metro, rural and regional district is I think we can do a bit better in that particular area. And not so much the occupational licensing, but we need to do something about if we are going to attract people from overseas. And I've got to say at the moment, the gap is there, and we do rely on our overseas graduates, is apart from the programs that we run, Hunter New England runs a very successful program in which we actually participate in a WBA program in which we assist a lot of the overseas graduates to come to grips with some of the what would I call it? The unique aspects of healthcare in the Australian setting. And we're doing very well there, and we're very lucky that we've got very good clinicians. Professor Kitchener, for example, runs that program here. And it's been regarded now as, I think, Australian best practice. But the issue about the occupational licensing is more about we need to do something about fast-tracking these visas and everything else that comes. The issue is we cannot get overseas trained clinicians. There's a lot of them that do wish to come, and I think we can do something around the occupational licensing, but we've got to speed up these processes. And I think there's a major disconnection here between what it does take to bring somebody over here through some of the red tape or some of the bureaucracy. Well, I'm a bureaucrat, so I can say that, about basically getting that done. And I think I've forgotten what else you want me to talk about now. But no, sorry, the workforce capital. The other aspect about this is I think COVID gave us the opportunity to look at some of that task-orientated information that you presented. And we need to now work on the basis that we need to re-engineer the workforce.
just a couple of examples that we're doing in our district, because I think we're a good example of, I think, the Australian health system in many ways, is we are challenging some of the historical and conservative nature of the way that we provide those particular tasks. We call those tasks. Without offending any doctors in the room, we're too highly a medicalised model, and over time we need to change that. And that is slowly happening, but could happen, I think, at a faster pace. Nurse practitioners are a classic example of how we should move to utilising that particular resource and that workforce under a scope of practice. As you know, nurse practitioners can operate, and they're only effective if we make sure that their scope of practice is actually evaluating in that particular team environment of providing care as a classic example. Another little example about how we can do little things which I think will change a lot of those tasks over time is we are in Hunter, New England, successfully have an arrangement now where we'll be asking our year 1 to year 4 medical students whether they want the opportunity to actually come and work in hospitals when they have the opportunity. And I mean work, that's not a clinical placement, as an assistant in nursing. So a lot of that is about there are those sorts of tasks that need to be undertaken. It doesn't necessarily have to be a nurse. And at the same time, it may actually assist in giving those very young doctors the opportunity to learn about, I hate to say this, compassion, care, and how to communicate with patients, which would actually make them a better doctor in the future. So anyway, I'll stop there at this stage.
Thank you very much. Well, I come to you. You're free to move around. Well, you were being found sitting on the purchasing side of things, and clearly, in sectors like healthcare, where productivity is a challenge, you have, as an economist, I have a temptation always to think about making the sector more competitive. Because there is, in fact, the temptation for the sector, to increase costs, and maybe these are rents really. Now, in some sectors, not only in Australia, that happens, is clear signs of monopolies and so on, and licensing plays a role. But from where you stand, how do you see purchasing of healthcare services from a payer standpoint in Australia, and how do you propose or think in terms of its potential contribution to making fundamentally the system more sustainable?
Follow the training guy at the front. I was hoping for an easy question, Francesco, but obviously not the case. So yeah, I come from a private health insurance background. I now work for a company called Newcastle Health, which is a joint venture between NIB and a big US health insurer. And we are trying to transform the healthcare system from our perspective. So your question's around improving the effectiveness of healthcare purchasing. So from my perspective, hopefully share, there's significant market failures from an economic perspective in healthcare. The purchaser of healthcare, whether that be the insurer or the patient, doesn't have any idea of the quality of the service that they're purchasing. There's no way to discover that in the current market, really. The traditional way of finding a doctor is ask someone else who's had the same procedure. Can you give me information? Anyone know who's a good orthopaedic surgeon? Anyone know who's a good urologist? When that information should be discoverable to people. So quality is not discoverable. Price is largely not discoverable as well in the market. So insurers have some information around that they're doing their best to make more available to patients and GPs. And I guess that steps into another related issue around the kind of agency issues that exist in the purchasing of healthcare. So still in the current model, it's largely from a private health insurance perspective or private medical care perspective, it's largely the GP who determines which specialist you're going to see. And in all the discussions I've had with GPs, they also don't know who is a good doctor in terms of achieving good outcomes and have very little information about what they charge compared to their peers. So now, just kind of broadening the question, I did, talking to Alex just before this discussion, I did read with interest the last Productivity Commission report on health, and all of the ideas that came out there, I generally agree with from memory. I can remember a few of them. Greater focus on preventative care. That's still very logical and true, and a focus on better connectivity of the healthcare system and digitisation of the healthcare system. Others have slipped my mind. They're all. But my point doesn't need them to make the point. All of them will remain good ideas. The real issue is a change management issue. The real issue is that trying to get some of these issues into development and working is hard because there's so many vested interests in health, and most of those vested interests are doing very well out of the current system. So can't really, the only way to address that question is to kind of work with the coalition, the willing, prove that things actually can work in a different matter, and then expand them. And then just coming back to your original question, the obvious answers are to define what quality looks like in the healthcare system as defined by the patient, start measuring those outcomes and other measures and make them transparent, so that all of the purchasers of healthcare can have that information to make better informed decisions. And that then should lead to everybody, the rising of all boats, I don't know the term, everyone moving to better practice, but more patients will see better doctors and therefore get better outcomes, and the efficiency and productivity of the system will improve.
Okay, thank you, Rod. Stick around, and any other points from the panel? Alex, you guys, no? Any questions? Okay, let's go. I'll go here, Penny, please.
Cheers, Francesco. Penny Reeves, I'm the Applied Health Economist. And I guess the thing that stands out for me for this is, the make best practice common practice. We're not great at making sure that best practice is cost effective. And I think we need to be a bit more forensic about that. And then the other thing we do is throw more money at ensuring we adopt best practice without making sure that more money is also not derailing the efficiency that we may or may not have with best practice. I think that's one point. And the other is a bit of a suggestion. So the idea of evidence-based medicine has been around forever, but we don't necessarily extend that evidence base to economic evaluation evidence. I had the privilege a couple of years ago of getting hold of some newly minted surgeons and anaesthetist fellows for a day to talk about health technologies. That's good. I know, I said to me. Thank you very much. And it started out a slightly uncomfortable concept for them, but by the end of the day, it's like this sort of radical transformation, and they were all going back to their hospitals and practice to question the value of expenditure within their environments, which I thought was really useful and something we should do a little more of.
Great. Any reaction to that? Otherwise, we go to your hand up for a second. Brian, go to you, and Brian, go right.
So hello, I'm Mark, and I do a whole range of stuff in medical technology. I think the conversation we're having around the move, I forget what you said, Francis, move and shift from a clinician perspective is one thing, but where we're seeing the big impact of virtual care or digital health or whatever you want to call it today versus next week is around the patients, and particularly around the fact that if you take some US data, there is a great disparity based upon the patient and how many miles they live away from their hospital system. And the ability that with virtual digital systems that we can shift and improve the access of the patients, but also improve the productivity of the patients. Because if you take, particularly the US where no one seems to get sick leave, people are having to attend a routine thing like to check a cochlear implant or a hearing aid or whatever else. They have to take a full day off work. And there's if you do take cochlear implants or any implantable device, within a 12-month period, there are 17 different appointments you need to have at a major metropolitan hospital. Well, if you live any distance from that hospital, that's a full day off work. So we're asking people to have a better quality of life through better healthcare, to take 17 unpaid days off work, and what that impact has to their job, their productivity, and everything else would be interesting to measure. So the more things that we can have people doing in the home, having connected up to the systems, because it's absolutely ridiculous that in order for me to check the settings of an implantable device, the patient has to come into the hospital when actually all the signals can be sent down a phone line much more efficiently using that technology. So I'd love to see more work looking at how the benefits of efficiency of the health system might be stagnant, but the benefits to society have actually become, maybe not exponential, but it becomes significant.
Point, yeah. Neil?
I mean, I can't agree with you more. So I chair the WA Country Health Service Board. So it's not the size of England, it's the size of 3 Texases. So, we've got 500,000 people spread over the whole of Western Australia outside of metropolitan Perth. And the social benefit I think you're referring to there of a patient, and it's the demedicalisation, which I think Michael talked about. It's about changing the practice about the doctors got to see someone in person. We have a goal to have no follow-up outpatient appointments for any country health patient in the next 2 years. I mean, we're talking about thousands of people flying to Perth with patients who travel to come to Perth literally for a 5-minute appointment with their follow-up doctor. And then they see the registrar who changed last month and wouldn't know them anyway. So it doesn't really matter. You know what I mean? So there's massive issues there. It doesn't necessarily change the budget, though, because what we're finding is this huge unmet demand and need, and it just keeps filling up. But it certainly is a social benefit to that individual, which and that's a very basic thing that I think is going to really transform efficiency. So, yep.
Thanks. Any other comments? Otherwise, Brian, please.
Yeah, thank you, and thanks for all the presentations. I'm particularly speaking as a doctor. Changes in training of doctors are really relevant in terms of what that means for the qualities and the attributes they have at the end of their training and the capacity to work across different disciplines. And in itself might address the issue of satisfaction, purpose, role, clarity, and so on structures overall in other competitions. One of the other things I wanted to ask about was the issue of Mark referring to social value and talk about productivity. I think the point you made about the skill quartet and struck me to think about the issue of disparities. We see it's not like in the area of cancer research, where we're improving cancer outcomes tremendously, but only for some people in the community, whereas for some in our community it's going backwards. And where does that fit into our vision around healthcare? Think about addressing those gaps, which aren't necessarily productivity, but a whole range of other social issues we have to think about.
Yeah, thanks. It's a good question for economists. I mean, it arises in other situations as well. I think the point that we would make is if you can specify what those are to the best extent possible, if there's a cost associated with this, let's know what that cost is, and then policymakers can make the trade-off. That's if they know what they're getting into, and it's a standard to the cost-benefit analysis more broadly. Is if you've got these other objectives, we're not saying that they're not important, or they're probably the most important things, but for the things that we, either let's try to measure them, or if we can't, let's say that we can't measure them, they're important, but then at least we go into it with eyes wide open. So these are the trade-offs that we want to do for these things that cost us something else in terms of what we might miss out on. So I think that's, as an economist, that's the initial way you approach it. I mean, you're absolutely right. So it's not saying that productivity in terms of how you measure is the only thing. There's a lot of things we miss out on. Now, hopefully it's positively correlated with all those things, but sometimes it's not. And that's one of the things that I'm not points out in this book, is that you have costs go down, all sorts of undesirable things. So yeah, we're very humble in that respect. But you know, with all these things, you know, particularly in specialised areas like healthcare, education is another one. We did this work on vulnerable supply chains, which is where the big issue is in Australia at the moment is the security of our supply chains. What we did is thousands of bits of data, and I'm sure what we regard as economists as vulnerable or essential. But ultimately, you have to talk to experts and say, what's that really make sense, and help some health of the supply chain. It's the kind of issue that we're talking about. To think about this trade-offs. That's why the commission, our mission is to be transparent and self-vital. That's always what we do.
Okay, thank you.
Last question, guys.
Thank you, James Juniper. Yeah, I just wondered, when you look at these slumps in productivity compared to the average, of course, we've had almost 50 years of neoliberalism, privatisation, competition policy, and that's been disastrous in areas like the energy sector, as most people will be aware. So yeah, how important is that as a sort of driver of productivity slumps, and what can we do about it? At the moment, the Republicans are doubling DARPA funding from $3.5 to $7 billion to try and cut off China as it tries to sort of leapfrog ahead of the EU and America in a variety of industries. And that's the sort of, how effective is that as a policy going to be in the health system?
Alex?
Look, on the last side, I don't know what the policy is, the US policy. I just don't know. I mean, on the reforms, more generally, I think the Commission will take a different view on a lot of those things. I mean, things like opening up Australia's economy, lowering tariffs, getting in foreign investment, opening up the economy to migration. All these things, I think, have been beneficial, on average to Australia. And so I think, in terms of productivity growth, it's the last 10 years it's really we've seen that slump. The years before that, particularly the reform era in the 90s and 2000s, were reasonably strong. So, I don't think we could pin the productivity slowdown on that. A, because I think the economics of it it's not the case, but B, it's happening in all sorts of countries where they haven't had that the reforms of Australia. So the OECD's 38 countries ranges from countries like Mexico, Colombia, Costa Rica, to France, Germany, Italy. It's a broad range of countries, and we're seeing this productivity slow down right across the board. And I genuinely think it's this issue of, as economies become more mature and get more activity going into services, it's just the fact that it's harder to secure productivity gains in those areas for whatever reason, and it just looks different.
So Alex, so what's the last 10 years? I mean, I can't remember, you might have said at the beginning. So what, is there a reason why there has been that slump? I mean, is it partly demographic as well, with baby boomers kind of coming out who maybe have worked hard differently to the next generations coming through who maybe not as, but I mean, I don't understand why it has been like that then. Is it because it's predominantly mining and that's, I don't know.
So, productivity growth is about working smarter, not harder. So I wouldn't say, people become lazier. I don't think that's part of the answer at all. There's some truth in what we say with respect to mining, in the sense that if we've got investments, it's very capital intensive, I have to start up a mine, I get into minerals which are very difficult to get at, and more marginal, So the output that I get from every unit of investment, won't be as much as I get from previous. So there's something in that they're long lived. So I can invest over 9 to 10 years, and then finally the output starts ramping up. So that's part of could be part of the action in terms of measurement. Other one is other infrastructure, so energy. We're replacing and we're transitioning to different forms of energy. So in terms of the inputs that we're putting in we're replacing old forms of capital with new forms of capital, and the output, it's not the same. And it's lower in many cases, it's variable supply. So that's part of the answer as well. But look, it's a good question. It's happening, as I said, all around the world. It's not just in Australia. And so that's why we look to things like innovation, building knowledge and skills, regulations, openness, all of these things that could be part of the answer. I think it's important though not to try to think about it too mechanically. So we can go and do all the empirical analysis and tell that bit of the residual with most activity, we can account for it, this, and this. But at the end of the day, it doesn't really help you that much with respect to policy. When someone can policy that can come to you and say, I want to increase multi-factor productivity by 5% a year, tell me what we need to do. It doesn't work like that in terms of targets. It's
Great. On that note, I would like to invite you to thank Alex and the panel, please. And also would like to invite you to our coffee and whatever else is there available. And I'm sorry, really, there were a few other questions, or maybe more than a few. I'm sure that the panelists would be happy to engage. I would like to ask you though, given that we are usually late, if you could come back in 5 minutes rather than whatever it was established before, because that would be very good. So I would like to reconvene around 2:38 for our precisely. We'll start at 2:38 for our HDR students presentation, which is very important. Thank you.
Yeah, absolutely. Yeah. Okay.
So what's going on? You want to get a coffee? Yeah, let's get a quick coffee. Have we got enough time? 2 minutes left.
Yeah, of course. Sorry.
Yes. That's okay. Yeah. Must have been you. Yeah. No, you must have been coffee with us.
No. You.
Yeah, no.
Yeah, so this is the right. Yeah, one of that. Yeah, so yours.
We're metro all the way to small little Aboriginal areas. It's hard.
Yeah. No, there's so much. Things have changed from big hospitals. I mean, are there going to be big hospitals being built in the next 20 years? Private hospitals are all going to be done. My stuff now. Yeah. So that's in place. Yeah, that's just in itself. That's what it is. Look,
No, the idea that, you know, I could say to 25% of my medical he refused to have one. He's a jealous. No, I'm used to go to well, yeah. I just don't think the other set in the same room, the whole concept of it is just take. So where are those 2 hours of face-to-face time going to come from? That's going to be the aged care. Aged care is heading for it.
Are you sure you're not coming drinking tonight? I mean, you're very weird today. Who's talking?
My fellow staff.
All right. Okay, welcome back, everybody. Yeah, sorry. I didn't. Thank you so much. Thank you for coming back. I appreciate your time and rapidity in coming back. Now, This is a research showcase. We have researchers and HDR. In fact, apologies for that. So what I said before, it's really researchers and HDR that present today. We start with Marcello Antonini, who's going to talk to us about a project that, in fact, do collaboratively with various groups in the university on vaccination hesitancy for COVID.
7 minutes.
7 or less.
Okay. Okay. Hi, everyone. So as Francesco said, I'm going to present the project that I've been leading in the last 2 years during my PhD, and that we built with Francesco, Brian, and other members of the University of Newcastle and the Value in Health Economics and Policy Network. So the name of this project is COVID-19 Vaccine Preferences, and is a database that tries to understand and identify preferences for vaccines for COVID-19, and also the related policy restrictions that people may face when it comes to handle a pandemic, right? From the policy perspective and from policymakers' perspective. So the idea was to build and administer a standardized questionnaire across different countries to really try to investigate how these preferences change in the general population across countries and across specific groups of people. A second aim of this project was also to investigate if there are specific characteristics that make Novax or hesitant groups of the population differ from those that actually get the vaccine. And these two things together, we wanted to investigate to support the governments in their response to the pandemic, because even if now it seems like a lower problem in the political agenda, we can still see that COVID is out there, people are still dying for that, and we don't know how much the vaccine are going to last. And we are also seeing a decreasing trend of vaccination for boosters, which is quite worrying. And so that's the reason why we wanted to keep investigating these preferences over time. Long-term objective of this project is to try to build a global vaccine hesitancy observatory led by UN, but that clearly try to look at as many countries as possible. Okay, so in these 2 years, we were able to include 19 countries in this survey, this global survey. We started with just Italy and Australia, and then we ended up with 19 countries. Actually, we are recently closed an agreement with researchers from the University of Newcastle in Singapore to include Indonesia and Singapore in this list. And this has been possible thanks to our effort in creating a global network with many different universities. We are collaborating with more than 13 institutions and more than 30 researchers. You can see listed here. If you want more information, we have a web page in the Value in Health Economics and Policy website where we explain all who these people are and what they do. And talking about the dataset itself, we have a quite large sample size because for these 19 countries, we have 43,500 respondents that are divided across these countries in the way that I report here. It clearly is a proportion of the population in each country. And what is most interesting, in our opinion, and the strength of this database is that we have, for each country, a sample that is representative for the gender, age, and geographical distribution in each country. Okay, it's a very strong and robust dataset where we can infer like preferences for COVID-19 and vaccines and policy restrictions. Okay, so I talk about the questionnaire, that is the main tool that we used. And the questionnaire is composed by many sections. On average, we have seen that it takes 25 minutes to be completed, but there are variations across countries. And the main component of the questionnaire is the discrete choice experiment that we designed and we built in this last year. Actually, many of you in this room have seen the questionnaire in early stage
such as Michael, for example, who kindly contributed through giving us comments on how to improve the questionnaire. And I wanted to show you the choice task that respondents face when they complete the questionnaire. So each respondent faces 12 choice tasks, and this is the example that I just report here. So you can see that there are two options where respondents have to indicate what is the favorite option for them. The novelty of our design compared to the ones that have been already published in the literature is that we try to merge the vaccine characteristics with the policy restriction features. And so these allow us really to see the trade-offs that people make in how they decide to get the vaccine. So are they willing to give some freedom away to get the most effective vaccines, or are they instead willing to get more freedom and take less care about the duration of the vaccine, for example? Okay, so just concluding, next step are clearly, it's clear to conclude the data collection for this first wave, analyze the data and provide recommendation, and then set the basis to start a second wave that will clearly help us to build the vaccine hesitancy observatory. So just stay tuned for these new steps, visit our website, and clearly if you want to contribute to the research, feel free to email us, or me or Francesco. With this, thank you, and give the floor to the next.
Chiara, please. Thank you, Chiara. Berardi.
Hello, everyone. I'm Chiara Berardi, PhD student here at the University of Newcastle. And today I would like to talk to you about the economic conjuncture that make relevant to understand what are similar health system reforms in times of crisis. So this is a theoretical framework. This is part of my thesis and will inform eventually also an empirical study. And I would like to give you a bit of background. So industrialized countries have implemented similar reform to address long-term challenges of inequalities, long-run cost growth, and inefficiencies. However, these challenges are exacerbated in times of crisis. And in the last 14 years, high-income countries have experienced many exogenous shocks, such as the global financial crisis, the COVID pandemic, and the ongoing inflation crisis. Previous research has focused mainly on the effect of these exogenous shocks on population health outcomes, but little research was done on their effect on health systems. So the aim of this framework would be to determine whether there is evidence of a new wave of reform in G7 countries in the last 20 years in response to these exogenous shocks and discuss the policy implication for healthcare systems. So in the analysis of the dynamics of international healthcare system reform, Cutler defined three main waves. What is a wave of reform are similar reforms that can be structural reform, demand, or supply, implemented in the same period of time across different countries that have a similar economic profile or background. So the first wave was after the Second World War and had as a main objective equal access. So there was the foundation of universal healthcare system across G7 countries, but in US. This was done in a period of economic prosperity. However, in the 70s, we have the first shock oil crisis, and the health system reform turned to, then there was the need to control costs, basically. However, this was done by constraining the supply, which increased perceived inefficiencies in healthcare system and increased unsatisfaction with the quality of services provided to consumer. So the third wave, mid-90s, had as a main objective efficiency with introduction of incentives and competition. So what happened after the third wave of reform? we have three exogenous shocks: global financial crisis, COVID pandemic, and inflation crisis. These are really like different crises in duration and nature. However, they can have similar impacts on the economy. So a decrease in GDP and in the availability of health system resources, and an expansion of the demand for health. Of course, these are good preconditions that trigger new reform agendas in G7 countries. And these include a revision of universal health coverage, so altering the balance between public and private expenditure or provision in the healthcare system, cuts or boosting health spending, and expansion or restriction of hospital capacity, like we saw during COVID. We know little about the ongoing inflation crisis and on the effect that it could have on healthcare system, but we can already see that in 2021, the share of public expenditure has decreased in all the countries, despite the GDP increased compared to the previous year. So to understand what is the response of healthcare system to exogenous shocks in the last 20 years, we systematically mapped and critically reviewed descriptive, qualitative, and quantitative evidence around reform trends in G7 countries. And we tried to understand what are similar reform trends based on similarity of objective and content. So I mentioned already Cutler three waves of reform that are in blue in this slide, while our findings are those in green. So two main themes emerged as a response to economic shocks. So after 2008, there was a general re-centralization of health governance in healthcare systems, and these partly counteracted the decentralization that was established to accommodate competitive measures during the third wave of reform. And of course, after the economic crisis, we have also austerity measures that are a combination of supply and demand cost sharing, so budget cuts or increase in out-of-pocket expenditure per capita in these countries. And during COVID, we see an increase in public expenditure to expand the hospital capacity and provide vaccinations to the population. So overall, we found evidence of similar reform trends in G7 countries in the last 2 decades in response to exogenous shocks. And despite the response to the economic crisis and to COVID-19 could seem different, because for COVID-19 we have an increase in public expenditure, while for the economic crisis we have austerity measures. The actual impact on the healthcare system goes in the same direction. First, need of an efficient health governance, so a tendency to re-centralize health system decision-making, and we saw this like during COVID clearly, and also a better rationalization of resources that include upward or downward revision of macroeconomic costs by central governments. So what are the implications of our findings? Healthcare system reforms in the last 6 decades have altered the balance between public and private actors' participation in the healthcare system. These changes to the public and private mix could produce unintended effects in terms of access, quality of services, and then, of course, population health outcomes. So why is it relevant to identify similar reform trends? First, to understand the present situation. So what is the response to these shocks and what are the implications for equity and efficiency? And this can offer like a future guidance for development of economic policies of the private and public mix in healthcare to improve resilience to future shock and strengthening healthcare system. And these are, of course, all shared objectives across like countries, also in the light of the Sustainable Development Goals of 2030. So this was my presentation today. Hope you enjoyed, and this is my contact if you have questions or feedbacks, which would be really welcome as this is an ongoing research.
Fantastic, both Chiara and Marcello, and now I have to get out of here. And we have Maddie. Thank you for being with us, Maddie. While you make your way, I load up your presentation. Voila.
Thank you. Okay, so I'm just going to run you really quickly in 8 minutes through how we might use causal inference methodology to help inform health policy, using an example from a study that I'm running, which is where we're conducting an observational target trial applied to the effect of a group of medicines which are P2Y12 receptor inhibitors on post-stroke dementia and cognitive impairment. And I'm an epidemiologist in the School of Medicine and Public Health here. So in public health policy, we need to make causal inferences. Treatment strategies for different conditions and healthcare interventions are becoming increasingly complex. And we need to compare these strategies in terms of outcomes for patients so that we can make policies about picking what to do. Randomised controlled trials, or RCTs, are the preferred option to try and make these causal contrasts to give us an answer about what we need to do in healthcare systems. And it's really important that we ask and answer questions that matter for healthcare systems and for patients. And the questions that matter, at least from an epidemiology point of view, where we're trying to improve public health, are questions that will improve public health. So whilst randomisation prevents confounding and allows us to relatively easily make causal inferences, RCTs can have limited applicability for clinical decision-making in some situations. So some of the limits of randomised trials include that they can have a highly selected population or a limited sample size. They can be conducted over a relatively short duration of time and be based on intermediate or surrogate outcomes rather than a final patient-relevant outcome. Comparator groups might not always be clinically relevant. We might need an answer to a particular question, or need to form a policy relatively fast, whereas some trials can take years to conduct. A trial might not be ethical to conduct. Trials can be costly and time-consuming, and we can't afford to run all the clinical trials that we'd like to run. And sometimes treatments or interventions that we want to compare are too complex to implement randomisation. So this is an example of a trial that we might like to run, but probably can't because it's looking at a long-term safety signal. So something that people would not fund a clinical trial when we're expecting a negative outcome for patients. So early preclinical studies in animals suggest that treatment with clopidogrel, which is a P2Y12 receptor inhibitor in rats and mice post-stroke, lead to cognitive deficits after stroke. So here is a control group of animals and a group of animals who received clopidogrel 2 weeks after stroke, and you can see that the animals who received clopidogrel are performing on average worse on a cognitive task. So the challenge is to use large administrative or health record databases to conduct comparative effectiveness research. So can we compare people who were and were not prescribed these drugs after stroke and see if they do differ in terms of cases of dementia or other cognitive outcomes? So the good thing about using this big observational data is that it can include large populations. It allows us to compare complex treatment and healthcare strategies if needed, and the data are relatively inexpensive to access. However, using big databases like this does come with challenges that need to be overcome in order to make reliable causal inferences. So using observational data means that we need to adjust well for confounding to ensure that a large set of potential confounders are balanced between our treatment groups so that we're comparing like with like. Sometimes there can be misclassification problems in the exposure or treatment assignment and the outcome. And sometimes there's issues with needing to use more than one administrative database to answer your question. So the availability of this big data sets is increasing, and I'm sure that you've all heard about it in recent times. Similarly, treatment strategies and healthcare interventions becoming increasingly complex, and COVID vaccines are a good example. So when we're trying to see, whether it's worth getting 4, 5 or 6 doses or booster doses, we're not going to conduct a trial comparing 5 to 6 boosters. So we look to observational data where people have already started receiving these. So the imperative is on us now to develop new methods that we can use to make rigorous inference using these data sources. So observational studies do have a lot of potential for bias and have historically been associated with a lot of issues in observational data analysis, including confounding, problems defining time zero or when to start having people in your analysis, problems with structural positivity, which is where you compare people who are always eligible with people who would never be eligible for treatment. And again, it's not the right comparison to be making. And so this little cartoon here is by Eleanor Murray, who's an epidemiologist at Harvard, who makes these little cartoons about causal inference, and it's sort of to highlight positivity. So the people that you'd want to include in your trial are the sometimes treated. Poorly defined causal questions have also been an issue with observational studies. So you really need to narrow down a question that is going to give you the answer to your policy question, and then other types of bias, such as measurement and selection bias. So the target trial framework is one structural approach to observational data analysis that can help us give really good answers to these sorts of questions using observational data. And the time that you might use this is when randomised trials aren't feasible to be conducted. So it's still challenging, but this is a really nice framework that can help us design an observational study to replicate a clinical trial. So it tries to avoid some of those biases that are commonly associated with the analysis of observational data caused by things like informative censoring, non-randomization, non-adherence, competing events, poorly defined questions, problems with generalizability and transportability, and incorrect interpretations of trial results. So what it essentially does, and it's really quite a simple concept, but it works really well, is that it asks us to think very explicitly about the clinical trial that we would run that would provide an estimate of the causal effect of interest. So we describe the trial that we'd like to run but cannot, and then describe how we could use observational data to emulate that trial. So it's a structural and a statistical approach to analysing these sorts of data. So it's looking at what we can learn from the conduct of randomised trials and applying that to observational data sources. So, for example, in our case, when we're looking at whether antiplatelet therapies prescribed post-stroke might increase the risk of cognitive decline or dementia, this is just a little bit of background. So it's because the immune cells of the brain also have this receptor on them that's also on platelets, and normally the brain would be protected from being exposed to that by the blood-brain barrier, but after stroke, when the barrier breaks down, there is a chance that these medicines can access the brain and inhibit the receptor from doing what it needs to do. And part of what it does is brain repair. So the risk is that by inhibiting brain repair, it will increase the neurodegeneration that occurs after stroke. So we developed a protocol for a target trial using observational data from Sweden, where they keep all these really big, lovely data sets. And this is, I won't go through it now in the interest of time, but it's published if you'd like to read it. And so that's setting up the structural method to do our analysis. And then we use a causal diagram to help us identify confounding bias. And it looks sort of like this, and you develop that with a lot of clinicians and decision maker input so that we can work out the right set of confounders. So historically, in observational analyses, people will chuck in all the confounders they can think of that have ever been associated with the exposure and the outcome. But we don't want to do that because sometimes that also introduces bias itself, and that could be a lecture on its own, I think. And then into the statistical methods, so observational data is also difficult to analyse in terms of who could be included and setting baseline or time zero, working out why some people were exposed to the exposure of interest or not. And the target trial framework really helps to clarify this, and then it provides a set of statistical methods which we implement to analyse the data appropriately. So things like inverse probability weighting, doubly robust estimation, and G methods. So all causal inference requires assumptions, including causal inference derived from clinical trials. In observational data, there's some very specific assumptions. So some of the ones that we are working with here is that we have no unmeasured confounding and that all common causes of treatment and outcome are known and adjusted for. So we do have a very rich multidimensional data set that we're using, and that helps with that. No open colliders, which sort of helps with this. So making sure that we don't have selection bias and that we're selecting the right people into the study. Positivity, as I mentioned before, that there's a non-zero probability for all people in the study to either have received treatment or not. And consistency, so that the intervention is well defined. So you don't want to the best example of this is if you are looking at a study to reduce BMI, you don't want to compare diet and exercise with like lower limb amputation, all of which will reduce your BMI, but through very different mechanisms. So it is hard to get these assumptions right, and it's still a very, developing field. Even if we specify everything correctly, we don't know if we've specified it correctly, but we are getting better at this. So there's some other studies being done now using this framework and benchmarking it against other trials to see whether we get similar results to existing big clinical trials and things like negative control studies. So where you can look at another outcome or another exposure that's not thought to be associated with the outcome or exposure that we're interested in, or looking in a different population, for example. So overall, when we're making causal inferences for health policy, we need to ask really good causal questions. So we have to be very clear about what we're asking, and then it's easy to use the answer to inform health policy. Answering the questions is hard. Ideally, we'd use randomized control trials. Observational analysis might be more generalizable, but there's a big drive to need to minimise bias associated with that. But I think that this real-world evidence or use of these big databases is here to stay. So NICE and ISPOR have both recently released big guidelines for the use of real-world evidence for health policy and decision-making. And yeah, they're quite nice to read too. So I'm happy to chat anytime, and that's it. Thank you.
Okay. Gina, thank you so much. And so I just decided that we won't have a break. We just go straight into the last session after Gina. So for those who are connecting online, our panelists, please welcome you better once Gina has presented. Gina, please.
Perfect, thank you. I'm going to present my PhD topic, that is the feasibility and health economics of implementing ICSAQUID, that is an evidence-based prevention intervention for smoking cessation in Aboriginal pregnant women. So first of all, I would like to acknowledge the traditional custodians of the land where we are meeting today, the Awabakal people, and extend my respects to elders, past, present, and emerging. So we know that there exists a gap between Aboriginal and non-Aboriginal health. And in terms of pregnant women, they are 4 times more likely to smoke compared with their non-Aboriginal counterparts. But on the other hand, they are willing to do the best for their babies. So this period is a window of opportunity to provide smoking cessation care. And the ICSAQUID intervention aims to train health providers in a culturally appropriate smoking cessation care to assist pregnant women to quit smoking. But before that, they have analyzed what Australian care providers were offering. So we know that in terms of asking and advising, they were doing really well. They often or always do it. But when we go down in the smoking cessation care, we can see that when they try to assist or set up a quick plan, these numbers drop. We have only 57% that were doing it consistently. In terms of setting a quit date, only 30% were reaching that, and similarly to arranging referrals. And when providing nicotine replacement therapy, we have low numbers. Only 14% were doing that often or always. And some of them were having some concerns about doing it. They don't have the training or they don't feel confident to do it. So ICSAQUID offers the ABCD approach. This was based on the New Zealand approach, that it was the ABC, but they have included the D, that is ask, assess, brief advice, cessation, that includes behavior change techniques and nicotine replacement therapy, and the D is discuss the family and cultural context. If we compare that with the national guidelines, we're using here the 5 A's. It's similar to the ABCD, only that the ABCD has the discussion of family context. But also here in Australia, we're just using the AAH, that is ask, advise, and help. And with the help, we're just providing the referral. So we're not providing, let's say, behavior change techniques or nicotine replacement therapy. We're referring that, and we are aiming someone else to do that. So the SISA-QUID is a study, is based on multi-phase study. I am just focusing on phase 3 and phase 4. And phase 3, it was a randomized control trial where they were offering webinar versus usual care. And the phase 4 is implementing an online self-paced training. In the trial, they offer the webinar, oral nicotine replacement therapy, smokalizers, printed material that are for pregnant women and also for the health providers. And in this ICC-QUID phase, that is the 4th phase, we have also embedded in the electronic medical records this tool that is going to capture the ABCD and is going to help also as a guide to provide the smoking cessation treatment and care. My PhD objectives were to explore the implementation challenges and enablers of the trial. That was phase 3. But also I am trying to find the readiness to implement after the training and perform an impact assessment and identify the factors that influence the health provider preferences of training. At the moment, I have only results of the first phase. We have invited 17 services to participate in interviews. Between 1 and 3 health providers were invited, and the interviews were performed by an Aboriginal external agency. And we have used the COMBI model for the analysis. So we obtained 19 interviews from 11 services. And in terms of capabilities, one of the main issues that we found, it was the staff turnover and role change. And also the fact that they need to do referrals for the provision of nicotine replacement therapy. In terms of opportunities for barriers, we found time constraints. But in terms of enablers, we found that the resources that we provide were useful and women were using them and the same as health providers. And in terms of motivators, one of the enablers is that health providers have optimism. They want to do the training. They want to provide smoking cessation care. But on the other hand, one of the barriers is the complexity of the problem. We know that there are other social determinants that are there, and women have stressful lives. There is intergenerational trauma, poverty, and other factors. And in conclusion, part of the recommendations that we have for translational research is that this type of mid-study analysis can improve the implementation and the service delivery model. What we recommend is to integrate the smoking cessation care into all the health practitioner roles, not just for the doctors, not just for the nurses or Aboriginal health workers. Everyone needs to be on the same page. Also, providing ongoing training is vital for this because we know that there's a staff turnover, so we need to try to keep providing training. And another thing that we need to measure is fidelity. If you have any questions, please feel free to contact me, and I will be happy to receive comments or feedback. Thank you.
Thank you, Gina, also for coming here all the way from Port Macquarie. No, where exactly? Douglas. Huh? Coffs Hour. Okay. Close enough. All right. So great. Now there is our last session. I have maybe 1 minute to make sure that our panelists. Mark, are you connected? Actually, does he hear me better here? Mark, are you there? All right. Timur, are you there?
Yes, I'm here. Thank you.
Patrick, help me. I look really. Timur is there. Does he have a microphone and a camera? I mean, yes. Something is happening. This is tele-education, Michael. Is it? It works wow, very well. All right, Patrick. Anyway, while we wait for Patrick, we're going to find the solution to this problem. By the way, I think it's very important for us also to thank Patrick. He's been doing for these last 2 days an exceptional work, and also before. Welcome, Minister. How are you? You hear us? Okay, maybe not yet. Well, I introduced the panelists. So who you see there is the Minister of Health of Azerbaijan, Teymur Musayev. He has invited me not long ago to participate in a series of workshops as he just started a very interesting journey in reforming aspects of the Azerbaijani healthcare system, in particular on developing a digital health strategy. So I thought it would be nice to bring some international context, given that these are topics that are also very relevant for us, and it's an ongoing collaboration. I thank him for making the time. In his busy agenda, I hope we can manage to make the microphone work. Dr. Teymur is a long-standing medical doctor. He has worked also in the industry of healthcare very actively, not only, of course, in Azerbaijan, but globally, managing institutions successfully, and of course, more recently, also in the public sector. I met the first time Teymur in an executive education class, in fact, and since then we've been in contact. And so, welcome, Teymur.
Thank you.
Thank you. Now, I hope Mark Fitzgibbon is there.
Yes, I am.
You can see him, okay? Maybe Rod, you can help us with some text. He's there. Yeah, I kept on sending. Yeah, here he is. Apologies, Mark, we're late, both of you.
No, that's okay.
Mark, thank you for joining us. Mark has been the chief executive of NAB, if I'm not mistaken, since 2002. He clearly has led the company through a number of changes, pioneering the demutualization and listing in ASX, and more recently guiding or navigating NAB in entering a new frontier, which is the National Disability Insurance Scheme participation. So thank you, Mark. He's been a very good contributor and supporter of our initiatives, and I'm very thankful. He's in fact on holiday, so triple thanks for him to join us today. I hope you can hear us, Mark.
Yes, I can. Can you hear me?
The volume is maybe something Patrick will now fix, very important. Now, I would like to welcome Penny Reeves, who is Associate Professor and Director of the Health Research Economics Group at HMRI. Penny is a great colleague, of course, a very important leader in health technology assessment and impact assessment. She has been researched and worked in applied economics and health services research, including the integration of economics and implementation science and microcosting methods, contributing really to a great extent in improving healthcare services provision. Thank you, Penny, for joining us today. I'm very happy to have Tony Gilbertson. Thank you, Tony, for joining us today. Tony is also a fantastic contributor. He comes every year to bring some finance wisdoms to our students, as well as many of you that are here. I mean, students have seen Tony before. Explaining complex things like activity-based funding that Alex mentioned before in a very intuitive way, and also making it extremely accessible. It's guaranteed it's not really a very simple thing to do. He's the CFO at Hunter New England Health, our local health district. Thank you, Tony. Now, I'm extremely happy to have two collaborators on a project that we've been doing, I don't know for how long now, Andrew and Michael with the Department of Health, trying to, I would say, evaluate the aspects of the public-private mix in Australia, and in particular, the regulatory framework that is currently operating in the private insurance sector. We will talk a little bit about this today, although everything is pretty much still under embargo, so don't ask us too many things. But one of the reports is out for public consultation, and hopefully the others will come as well. Andrew is the principal and actuary at Finity Consulting, also associate professor at the Monash Business School, a great colleague. I met him several years ago discussing private insurance when he was the chief actuary at Medibank. He has a long-standing experience in the private insurance sector, and he contributed to the literature on risk equalization in Australia in a green book that has been published a couple of years ago, edited by Maguire and Van Cleef. I believe it's Routledge. I may be wrong. Escapes. I also contributed to that book, but the publisher escapes for a second. Now, it's very good also to have Michael McCrean, who's part of the team at Finity, who did together with myself and Manos and others a very thorough exercise trying to, in fact, estimate out of an experiment survey price elasticities for private insurance demand in Australia, which is very exciting. It's the first time that's been done. It's been great to work with him, and Michael is at Finity, has been at Finity for the past 15 years. Now, you can stay where you are. I'll try to walk around, or if you want, you can come here so you can save me some exercise, but up to you. And I would like to run this as a conversation. So I will have some points of discussions, and I would like to start. Mark, you hear us? Can you unmute yourself, please?
There you go. There you go.
Fantastic. Okay, I would like to start from the virtual world. So, Mark, thanks for being with us. I would like you to just start by telling us a little bit about these recent developments at NIB and the NDIS. If you could tell us a little bit about that experience, the idea, where it came from, and obviously what are the plans, if possible.
Okay, well, happily. So Australia has a large national disability insurance scheme called the NDIS. I'm getting some feedback there. Francesco, is that something I can control, or?
We're fixing it. I mean, by we, I mean Patrick.
So it's a national, yeah, that's better. So it's a national insurance scheme, you know, designed to protect people against the risk of themselves acquiring a disability or having a child acquire a disability. And interesting, you know, the majority of participants, as they're known, amongst the 500,000 Australians who are now eligible for NDIS funding, are children. participants under 17 years of age. So it's a very large social insurance scheme, fully funded by government. And as I just mentioned, there are about 500,000 Australians who are eligible for participation. The total spending on the NDIS is $30 billion a year, so it's very large. It's almost as large as the entire private health insurance system. And it's forecast that by 2030, there'll be 1 million NDIS participants, and the spending will be in the order of 60 billion. So it's a very large slice of Australia's economic activity. We've long considered ourselves as being able to create value for participants and all the stakeholders in NDIS as an agency in the NDIS. So if you think about in the NDIS, there's now a middle earth, if you like, a layer called Plan Management Support Coordination, and the role of that middle layer is to provide a level of independence for helping the participants design their plans and then source the necessary services and products and support that they require. Prior to the NDIS, there was no real independent agency layer, and that seems to have resulted in all sorts of conflicts of interest and issues for the NDIS. So just as we've played an agency role in connecting the buyers and sellers of healthcare services for 70 years now, we see ourselves as playing a role, an agency role, in connecting the buyers and sellers of disability services. So that's the thematic that got us interested in the first place. We think we can add value for participants by harnessing the kind of data science we're developing for healthcare to help participants make more informed choices about how they meet their objectives. We obviously have a long history and expertise in contracting with service providers. In the case of healthcare, doctors, hospitals, dentists, etc. In the case of disability services, it'd be different, be more home-based services, transport, psychiatric care, etc. And so we think that contracting function that we have will be good for the system and creates a business opportunity for us. We think there's a natural confluence between disability care and healthcare. People with disabilities are every bit as worried about their healthcare and outcomes as they are anything else. And of course, we have a reputable and trusted brand, which we hope we can use to good effect in growing the business organically. And I make that last point as a segue to the fact that we're starting off in entering the NDIS inorganically by acquiring a number of existing providers, and just recently we raised about $150 million in capital from the marketplace to fund that M&A program. So that's the guts of it, Francesco. I can't hear you.
Do you hear me? Do you hear me?
Yep, I can hear you now. Yeah.
Okay, good. Now, I would like to go to Andrew Matthews on this, and we've debated a few times, and this news from NIB is very interesting. We debated a few times about the role of funders in the Australian healthcare system more broadly, also disability and aged care. And when I saw the announcement, it came to mind immediately the value proposition, and Mark just described it. But there are pockets in the healthcare sector that are suffering from high out-of-pocket payments, for example, some more than others, and clearly price pressures are there in the system. We discussed it before for structural supply-side reasons. But also in terms of coverage. Of course, there are regulatory barriers like in GP care. But where I want to go with this, Andrew, is fundamentally, what are your thoughts about, in fact, expanding the participation to the purchasing activities by funds and or in general characterizing the healthcare system as a more contestable marketplace?
All right. Welcome. Friday afternoon, and I get to talk about what funding and risk equalisation and things like that. So your question, do we make it a more contestable market? I think one of the problems in health insurance and health generally is, you know, if you go back to the goals, and Chiara, you talked about some of those, we want the market to be accessible. We want there to be quality healthcare, and we want that you can't avoid cost, right? And Mark just talked about, you know, bringing some advantage of cost to the NDIS system. So you want people to be able to access the system. You want people to get quality care. Think about yourself if you enter it, and the system has to be affordable. So, you know, I think, Francesco, when we bring all those three together, you can't afford to have an unregulated free-for-all market. And then you combine that in Australia, we've got a market that has grown up. We've got public and private delivery. Now, I see some articles in the newspaper where people say we should have an NHS like the UK. Well, we don't. We have a mixed public-private system, and now we need to fund it. So this is where, you know, I get to give an advert on risk equalisation, and you go, oh, what is that? So let me give a little thumbnail on it. Risk equalisation, why even have it, right? Because we don't want to encourage risk selection. By risk selection, I mean, I run a health insurer, or say Mark does, I just want to pick healthy people because they'll pay me premium and I won't get many costs. We don't want to encourage that. So why do we not want to encourage risk selection? Because we want to have community rating. It's not my goal, it's the goal of the health system, because we want the system to be accessible, right? Call it premium regulation, if you like, right? We happen in Australia to call it community rating. So why risk equalisation? To avoid risk selection. Why avoid risk selection? To support community rating and make the system accessible. So we've been working on a project where we've got a report out at the moment. The report really thinks about 3 criteria for those risk equalisation, for the risk equalisation parameters that Australia has, right? So the first one is we want to go towards a system that's efficient. By efficient, I mean there's no waste, that their costs are controlled, that the players in the market, whether it's a health insurer or anyone else, are encouraged to do that. Can risk equalisation create efficiency? No, but it can reward it and encourage it. So that's the first thing. We want to go towards efficiency. The second thing is we don't want anyone in the system to get penalised because they have a bad year. So if you happen to insure some vulnerable people and they have a high cost that year, you'll be protected a little bit from that, because otherwise you would avoid insuring them, and that's not good for, you know, what you talked about, Chiara, the accessibility of the system. The third thing we want to do is we want to avoid risk selection. So we don't want to encourage the players in the system to go after good risks. So let me try and give you an analogy for that. If in the Olympics we set in place a drug testing regime and we tell everyone what that drug testing regime is, and we're never going to change it, ever, then that would encourage the players in the system to perhaps invest some money in circumventing and getting around that system. But we don't want that, because that's not fair competition. So we want it to avoid selecting good risks and avoid spending a lot of money on that. We want to have a system that encourages players to have better quality healthcare, not better quality risk selection. So they're the 3 criteria. If they are the right 3 criteria, we want more efficiency and we want to reward it. We want to protect players in the system from a really bad year. And the third thing is we want to avoid risk selection, or we want to avoid the players in the system spending a lot of money to game risk selection. If they're the 3 criteria, I think there's a better, our work would say there's a better system than Australia currently has. So you could challenge the criteria, arguably. No one has so far, because we got to them by talking to the industry and so forth. But if they are the right criteria, then there is a better system than what Australia has. So then we're left with then we're left with the problem of, can you get to that better system? We are where we are today. Can you move towards it? And that's where we are right now, the industry discussing that. And here's my reflection. I don't have an answer to this. There are 3 levels that are going on in the discussion. Level 1 is, Mark, you can comment on this, but an individual health insurer would say, what's in it for me? Am I a winner or a loser? Right? Level 2 would be, and we talk a lot about it, collaborating, but it's very hard to do. Level 2 would be, is it a better private health insurance system? That's really been the focus of our work. And level 3, perhaps that's more for the government of Australia, is it a better health system overall, remembering that it's got public and private? So I'm getting questions that are sort of from those 3 levels. That's very fascinating because I've heard it today, we're going to collaborate more, but collaboration is really, really hard because at level 2, you have a better PHI system, but the players in the system are the ones that have to reap the benefit and show it up, and they're going to ask, what's in it for me? Am I a winner or a loser? So you always in collaboration are wearing at least 2 hats. Is it a better system? When you're sitting at a table with everyone else? Yes, no. And then when you go away from the table, you wear your other hat is my agency better off? And this is the dilemma we currently face.
Yeah, very, very interesting. I'll get Mark to react to this in a second. I'd like maybe Tony, if you don't mind, you can come here. Yeah, to bring you in the conversation, because you've been working in the public sector. And clearly, the interface with the private sector is something that you've experienced. No system obviously is perfect, and there are improvements. Our project clearly points at trying, and Andrew went in the very core of it, trying to utilize best practice in essence to try and better connect those 2 systems. So what has been, not only in the past 2 years, but the experience with the particular mix that Australia has, which is clearly very unique. Yeah, thanks.
Thanks, Francesco. Sorry, I got a bit of a hoarse throat, so apologies for that. Yeah, it's a good question. I mean, the word collaboration's come up a couple of times. Sometimes it doesn't always feel collaborative, though. It feels more competitive between the 2 systems. And I guess, particularly when you've got a workforce that's scarce, and especially the high end of that workforce, if you like, the sort of procedural work and the other stuff that is highly specialised, they tend to work across both systems. But like any system, capitalist market, the kind of the effort or the resource moves to where the most money is at times. So that's the competition bit. But I guess the collaboration bit is probably a bit like we've seen through the last 2 years with the collaborative care arrangements in place with private hospitals, where we've had access to access so that public patients can get access to private hospitals to have their surgery done, because we've got obviously across the system a lot of people who have unfortunately become overdue for their procedures because of disruptions to activity, etc. So, but I'm interested in answering Andrew's comments, because I think there probably needs to be a bit of a reset in that balance between the public and the private. And I don't have the answers to what that looks like, but I think the scarcity of the resource in terms of the workforce is probably going to force some of that change, and will be necessary, and the cost as well, because the cost to both the consumer of healthcare, but also to the system, either through government provided healthcare or private, isn't going down, and it's probably going up at a rate faster than CPI, etc. So I think post-COVID, it's probably an opportunity to really reflect and perhaps structurally make some of those reform changes once we get through some of these elections, obviously. But Yeah, it's probably all I've got at the moment.
Thank you. Now, so I would like to go to Tamer, and you hear us?
Yes. Do you hear me?
Okay, we can hear you. Very good. So I know it's a very, very fast and crash course into the Australian system, obviously. So I'm making a bit of a connection when I came. So Azerbaijan has made incredible progress in the structure of its system, coming from a very high percentage of out-of-pocket payments, which was and still is, in some sense, the primary source of funding. And the government has introduced a series of reform that really try to address that particular issue. So, Tamer, we would like to hear from you about the recent changes in the financing and how you see the recent shocks or challenges playing into these recent reforms. Thanks, Tamer.
Thank you, Francesca. For me, it's a great privilege to be among you, all of you today, and being far from Australia, more than 14,000 kilometers, and have a chance to be in touch with you. I would like really, as you mentioned, a lot of efforts done, and since 1st January 2021, actually all countries covered by mandatory health insurance system. And this is kind of new financial mechanisms that push all healthcare system towards a sustainable financing mechanism. Starting from April 1, 2021, so sustainable financing of the national healthcare system, mandatory health insurance covers the entire territory of the Republic of Azerbaijan. The purpose of the mandatory health insurance system was to improve the existing financing mechanisms in the field of healthcare on a new economic basis to further improve the quality and availability of medical services provided to the population. Health benefit package covering a wide range of healthcare services has been drafted with this regard, although we're still in a process of optimizing the package itself, as we see that certain services could wait a bit more for their implementation. The package basically includes primary care, emergency, specialized outpatient care, laboratory services, physiotherapy, invasive radiology, surgical services, and inpatient care. And I would like to mention especially that three major fields like psychiatric care, oncology care, and ophthalmology is covered by special government program and financed directly from the budget. Actually, we faced with rising cost of healthcare, and as we see, the rising healthcare spending is a concern for our governments. But in order to reduce the cost, the behavior of both governments and populations should be changed. And expectations from our population towards mandatory health insurance is quite high. But what we see from our experience, I would say that one of the biggest part of the work to be done for implementation of this financial institute is to increase awareness or responsibility of populations for their health care, for their health issues. Because without that, we can continue increase our spendings in this field, but outcomes by means of social demand will not be compelling with the investment done. Comprehensive data is essential for health leaders to identify the improvement areas that will enable cost savings. The governments alone are not able to invest the huge amount of money needed partnering with private sector could release the financial burden of governance and at the same time increase the quality and accessibility of healthcare services. And Francesca, thank you again for participating during that few days in Baku when you brought your vision towards implementation of kind of engagement of private health insurance together with mandatory one. It's clear that we are at the very beginning of the long journey, but having knowledge derived from experience of countries like yours that already passed through this turmoil period with implementation of insurance, we can avoid, as we see, certain pitfalls that basically break down a bit the rise of the quality of the services and also financial mechanisms standing behind. Also, investments in medical wellness could provide in the long term better control for rising costs of healthcare, as I mean. So with this regard, we started strategic planning for promoting wellness, let's say wellness trend among population. It's not easy. I would say that 10% of population somehow tend to follow this trend. We should push this direction by including certain options for wellness expenditures for population to be put in a health benefit package. This is just short remarks regarding what's going on in my country right now.
Thank you. Thank you. Now, so I would say bottom-up activity in the Australian context, going horizontally, entering new sectors, also possibly, I think, because of the lack of regulatory channels for expanding partnerships between public and private in healthcare or aged care, for example, and top-down approaches, in fact, trying fundamentally to achieve similar objectives. And we saw some of the trends that indicate that, yes, universal coverage is always in our minds, but the universality doesn't necessarily mean at the same time that the systems underneath are really providing enough financial coverage and also enough coordinated access to care, which is, I think, the last piece of the puzzle that I wanted to put in the mix here when we think about the funding of care and the gaps that we observe, not only because of the silos in funding, but also between care and sometimes care and social services. So I'm thinking about integrated care and funding. I'd like to bring in Penny. You want to come to comment about this? That's work she's been doing. Thank you, Penny.
Cheers, Francesco. Yeah, I think you said it's going to conversation, and I feel like this conversation is woven all over the place. I'm clearly not an expert in the private health insurance industry, but I just do want to make a couple of comments. I mean, I think, Rod, you mentioned about the market failure and the reasons that underpin market failure, and I think, Tony, you just mentioned that idea of things being competitive, not necessarily collaborative, and I think there's so many moving parts to this particular picture, and it really is quite muddy. And I think the other observation I've had from the conversations today was around the emphasis on the need for the emphasis on preventive health that Alex mentioned to ensure or shore up the sustainability of health systems. And I just want to deviate to a brief story where I had the opportunity to be reviewing a cost-benefit analysis that had been put together on behalf of a private insurer who'd been looking at the cost benefit of their wellness program, I guess as a risk mitigation service to try and risk some of their costs. But it was a very didn't have a particularly robust evidence synthesis. The cost-benefit analysis resulted in the provider of the wellness program having their contract ceased. So there were some tensions there, but it would just concern me that the reliability of the data that underpinned that analysis was a bit questionable. So I feel like that lack of transparency and the fact that we don't necessarily have a good grasp of the underlying costs of the activity that occurs within health, both in the private sector and also in the public sector, doesn't help us. I think that's one of the big challenges, and I observe that regularly. We do a lot of economic evaluation work, and that difference between the financial cost or what's being paid for versus what we would consider to be the economic or opportunity cost, and that idea of waste. And when we do look at opportunity cost, we see there's so much capacity to do things differently with the existing stock of resources to get those sorts of productivity gains that Alex was alluded to. So that's a bit of a deviation from the question that Francesco asked me, but I wanted to just raise those. I think a specific example with integrated care, there was an experiment where the federal government provided some funding to some health districts to look at outcomes-based commissioning. And this idea of you could either be paid up front or you could take a 100% risk, I suppose, and be paid 100% by outcomes. And it was a really interesting experiment, and it didn't go particularly well. I think about 6 months into this, the outcomes, so the outcome measure was around readmissions to hospital, and I think 6 months in they'd sort of met the upper threshold, and so clearly they weren't going to be paid anything. And just the whole experiment, if you like, just raised a great number of questions around that risk sharing idea and the lack of visibility to information to be able to enter into an agreement like that. And economists have been talking for years about how we should be pushing for outcomes-based funding, outcomes-based budgeting, and certainly New South Wales Treasury have been moving in that direction for the last few years. But I don't think as a discipline, economists have actually come up with some great answers and models for what that should look like, and how we do manage that risk share when there is asymmetric information and so on. So I think that's still a really big nut that we need to crack, and hope we get some collective minds on it. Thank you.
Thank you, Penny. So maybe, Mark, coming back to you, I try to collect some thoughts around this issue. So I would like to go back to the original idea. Perhaps the question is more, of course, related to the future role of, if you like, of private insurance, and in relation to what Andrew discussed before. In particular, I would like your thoughts around the role in relation to dealing with increasing out-of-pocket spending, and how you feel about the regulatory barriers in some of the sector, like general practice, Medicare in general, and also some thoughts about this risk equalization instrument that really serves to, in fact, position insurers on an equal footing to manage better and invest in efficiency rather than selection activities. Is there a muting situation? I mute myself.
Sorry about that. So we're here to Monday, are we? Listen, some high-level thoughts just in respect to the conversation so far. My first observation, maybe for you, Tamer, if you're starting with a clean slate, you would not have government providing healthcare products and services. You would have government ensuring that the market was as efficient as we could make it, and its role is to regulate that market, for example, to ensure safety and health outcomes, and ensure nobody gets left behind in the system. So to redistribute incomes through taxes and subsidisations to achieve those equity objectives. The only reason we have government running hospitals and other healthcare assets, they're purely historical. If you're starting scratch today, you wouldn't do that. In respect to risk equalisation and the challenges we have there are just part of a total flaw in our thinking around community rating. Community rating actually doesn't work unless health insurance is compulsory, because the younger good risks simply select out of the system. And somewhat paradoxically, we actually want good risk selection because the system as a whole needs to encourage younger people into the system. Otherwise, it just becomes too expensive because it's full of older, typically sicker people. So, but we don't have compulsory health insurance in Australia. So the best we can do in the meantime is at least make the risk equalisation system more efficient by, switching it from the purely retrospective system it is today to a more prospective system where health insurers are rewarded for, investing more and hopefully achieving better outcomes around, wellness, etc. The final point around outcomes is an interesting one. I've just got back from the USA a few weeks ago, and pretty much, and in the USA and other parts of the world, they talk about the shift to value-based contracting. So away from paying for volume on a fee-for-service basis, more towards paying for better health outcomes. Now, the problem with that is, it's already been alluded to, is measuring health outcomes is really hard. It's difficult to risk adjust for those outcomes. Of course, if you don't do that well, there's a risk that the best doctors are penalised because they see the sickest people. So the world still hasn't come to grips with how we can adequately risk adjust the pay and outcomes. And of course, across the case mix, so many outcomes require longitudinal data. You can't really assess an outcome over a few months. You may need 5 to 10 years to assess an outcome. So the trend in the USA and North America generally is they say, well, look, if outcomes is too hard, how about we pay for activities or behaviours by the doctors which the evidence suggests will improve outcomes? So you're not actually paying for the outcome, but you're paying for a change of behaviour and an activity which, as I say, is consistent with evidence. So I think we're more likely to see a shift towards value-based payment, not based on outcomes per se, rather than paying doctors and other clinicians, rewarding them for adopting certain behaviours, such as registering their patients in whatever relevant program might be available to them. And that's probably the nearer term future. Was there anything else? There was something else you mentioned there, Francesco, I may have missed, recognising it's such a broad remit.
Yes, I know, but you did very well. And I suppose that the point was related to integrated, I would say not necessarily care only, but integrating the funding silos. Obviously, you're moving into NDIS. It's clear the vision. I think it's something definitely interesting and an interesting value proposition. And a comment on the barriers that the industry faces in entering other areas where you see gaps in coverage, definitely increases or pressures on out-of-pocket payments, like Medicare benefits in general practice or primary care and the like, which ironically also might do the trick for your low risk in a sense, because low risk individuals, if facing a premium rather than a full flat, let's say, not bug bid, full flat cost of GP care, might indeed find products in insurance that are more accessible to them. And that discussion in private insurance, not the industry, but really in the overall public-private mix hasn't really emerged yet.
Australia has a real problem with out-of-pocket expenses. It's 18% of our total spending. Like even in the much maligned US, it's only 8 or 9%. So we have a real problem with out-of-pocket expenses, and they are typically very regressive. That in as much as they hurt people of lower socioeconomic means compared to those of higher socioeconomic means. There are many parts to it. Our inability to cover people outside of a hospital is absurd, and with policy logic lost in time. You know, we should be able to help people. We should be able to help people pay for the healthcare wherever they meet the healthcare system, not be locked inside of a hospital gate. And so, you know, that's certainly reform, which is top of mind and top of agenda for me. But there are many other areas where people suffer egregious out-of-pocket expenses. And, you know, I think it's on our industry to think about, well, look, you know, how can we play a role in assisting the affordability of those services as well? And so, for example, as a company where we're investing heavily at the moment in women, you know, various men and women's health products, you know, through an acquisition of a company, a Brisbane-based company called Midnight Health. Now, you know, people will still pay for those products, but hopefully through our, you know, purchasing power, our scale and efficiency, those kind of, you know, men and women's health products will become all the more affordable.
Okay, thank you. I guess, Michael, I would like to hear from you. I think it's important, you know, to bring it home in a sense, because ultimately what matters, it's the consumers or the patients in healthcare. And we've done this great effort, I suppose, to try and estimate elasticities for private insurance. So I know that we can't say too many things yet, but it would be good to hear from you what you have found, and a little bit on the design. Michael is also doing, well, he's also from Finland, but also doing his PhD here with us on this.
Thanks, Francesco. So I guess, yeah, what I'm about to talk about kind of links in with the theme of the community rating, which Mark has touched on before. So obviously, as you know, we have community rating in Australia. Is this working? Sorry. No, I'm sorry. So we have community rating, in which means that younger, healthier consumers have an incentive not to enrol in the system, but they're the ones we need in the system to provide the funds to make it financially sustainable. And Finity, in collaboration with Francesco and Manos and his team, have been recently completed an actuarial study for the Commonwealth Department of Health to look into this. There are, because of the community rating, there's a number of incentives and surcharges that are built into the system to encourage those younger, healthier consumers to enrol. So there's the Medicare levy surcharge, the private health insurance rebate, the lifetime health cover loading, and there's also an age-based discount as well. These have been around for about 20 years in their current form, with a few minor adjustments along the way. But what the Department of Health was interested in knowing was, are they working? What are the effect of these incentives and surcharges? What would happen if we were to make changes to them? So we ran an economic experiment to work this out. So we ran a fairly large consumer survey, about 1,500 people, with a series of hypothetical markets presented to the respondents. What we did in these hypothetical markets was to say, well, imagine if we change some of these settings, and the respondents were given a set of products they could choose to purchase or to opt out of the system. And by creating a smart design where we vary all of these incentives and surcharges, we were able to do some analysis to work out, for each of these, if we were to adjust them, what would be the impact on participation and on product choice. So the other thing beyond just participation is there's a series of product tiers with different levels of coverage. So this is very interesting, and I can give you a few stats just because I'm a statistician. I love statistics. So for the MLS, it's quite a powerful tool. So we estimated that if you to change that by 1%, you'd increase participation by about 11.5%. That's that's probably quite a brave change to make. That's if you would apply to everyone across the board. But that, given participation is about 45% today, that 11% is quite substantial. The rebate, we found that it's actually not a very powerful tool with if it was just small changes we're thinking about. Doesn't really respond to small changes. If you drop it, if you remove it completely, you would probably see some change. There'd be about 4.2% drop in participation. And also with the MLS, if you remove that, you probably see a drop of 2.2% participation. There's also a bit of impact on upgrading and downgrading in terms of if the rebate might make gold and silver products cheaper. There's a bit of upgrading that you might see as well. But otherwise, rebate, we didn't find it's actually very significant in driving participation. We tested a whole lot of other scenarios as well. For example, if you would apply the MLS to bronze and basic products, you could incentivize people to purchase higher levels of cover. The LHC we found was not very impactful. We didn't find significant evidence that it was having a strong impact on participation, which is interesting. It's been around for about 20 years, and I think upon its introduction there was a big impact, but its impact over time I think has decreased somewhat. So this is a really useful tool for policymakers to evaluate potential reforms they want to make to the system. But I think one of the big things coming out of it was that none of these is a silver bullet. There's no small tweak you can make to any of these to suddenly move from 45% participation to, say, 60% participation. They're all, there's got to be other more broader changes to the system to drive that really high levels of participation. That otherwise we're kind of stuck in the sort of 40 to 50 range of participation going forward with the current system as it stands. Is that?
Thank you. All right. I think we're coming to closure here. We're over time. Thank you, Michael, for concluding with the last piece of research policy contribution, I would say. Thank you all for coming. I will ask you if you have any last points, of course. Yes, Brandon, I would like you to, in fact, close the meeting. Yes, you are.
So my last point was actually just to thank Francesco. So a round of applause for Francesco, please. So as co-lead of the cluster, I had a very good time because I had to go back to Ireland to run a charity event just when we were organizing all of this. So you certainly pulled it together, mate. I highly appreciate that. And again, it comes down to the quality of the speakers. So we've had incredible insights shared here today. Big hat off to the 3 students who presented, because being told you've got 8 minutes to get a lot of ideas across, that's part of your training, my friend. That's exactly what happens for your entire academic career. But taking away from this, look, we learned a lot in this, in the sense of there's a lot of content we learned. So if I listen to the conversations here, we're seeing lots of problems. And for academics, we love problems because we want to study them, right? So, the contribution of those insights and those problems being shared is that we start to ask research questions to try to address those problems. So that's really useful for us as researchers. And the second thing we do in the university is we educate. So when I listen back to the first conversation, we're talking a lot about supply issues in the health workforce and productivity around that. But I was thinking to myself, well, we've got a major role to play in the supply part, not just in terms of getting people, but making sure the people that enter the health system of the future have the right attributes and skills to actually make the changes that we've been talking about. So there's a massive learning for us in these conversations, even though sometimes, as Penny said, they go in different directions. we do pay attention and really appreciate the contribution everybody made. So thank you very much.
I guess you forgot about the drinks, Brandon. I don't know where they are. I mean, look for some drinks. They're somewhere. I think they're right outside. Compliments of the business school, I guess. I'm not sure if they are alcoholic or not, but they are liquid. I don't know the policy, but you guys know better than me. I want to thank again Alex, who's come from far, Neil as well, also Penny, Michael, Tony, Rod. Francis was gone now, Brian again, and you guys as well for coming all the way from Melbourne and Sydney. I hope you enjoyed it.